All right, good morning. We're going to get started in just one moment. So welcome to our May meeting. I'm your chair, Mark Galley, and I'm happy to be joined by most of my colleagues on the board here in the room. And I know one of our members, Dr. Pan, is joining us virtually. So we're excited. We have a lot of meaty PowerPoints to get through towards the end of the agenda, some very important issues at the front end, and we want to just dive in. But before we get into the substance, let's take roll and establish our quorum.
Great. Secretary Mark Galley.
Present.
Dr. David Carlisle.
I'll say here instead of here.
Dr. Sandra Hernandez. Richard Cronick.
Here.
Ian Lewis.
Present.
Elizabeth Mitchell. Present. And Dr. Richard Pan.
Present. Virtually.
Thank you.
Great, thank you all for making the trip here and for joining what I believe is going to be a very key meeting for our future work. So to run through the agenda, I'll turn it over to Director Landsberg.
Thanks very much. Thanks very much, Secretary Galley. So in our agenda, Vishal Pagani and I have some updates, both about the department and about the board's work. We have a new format that Vishal will be talking about. So our consent items, we have our minutes. We have an action item on establishment of the advisory committee. Then we anticipate taking a lunch break, and in the afternoon, delving into some more of the design considerations around total healthcare expenditure. In terms of HCI department updates, I did want to mention two items that are part of the governor's May revision of the state budget that just came out a week and a half ago. The first is the distressed hospital loan program, and then some proposed changes to the CalRx program. So again, we'll continue to give you all some updates about HCI's work that we think relate to the work of the Office of Healthcare Affordability. So we are, there's been early action taken by the legislature to create a new distressed hospital loan program for the state of California with $150 million. So this will provide interest-free cash flow loans to nonprofit hospitals and public hospitals that are in significant distress, or to governmental entities representing a closed hospital. And the express purpose of the loans is to prevent the closure of or facilitate the reopening of these hospitals. So HCI is undertaking this work with CHAFA, the California Healthcare Facilities Authority. We are moving very quickly to set up this new program. There is a webinar this afternoon about the eligibility criteria as we look to stand it up. I also want to mention some proposed changes in the budget to our work on CalRx, which shares with OCA the goals of increasing affordability, access, and equity. So the May revision includes $30 million from the opioid settlement funds to support the development of a lower cost generic version of naloxone nasal spray through a new CalRx naloxone access initiative at HCI. So the CalRx partnership will enable the state to make naloxone more accessible statewide. We know that naloxone is an essential tool in combating the opioid epidemic, and increasing access to this medication is critical. Compared to injection form, the nasal spray formulation is very popular and can be administered by non-medical professionals. So both the branded and generic naloxone nasal spray, both the generic and the brand name prices are still, we believe, artificially high for several years, which of course is an access barrier. So those are the department updates I wanted to give. I also wanted to talk a little bit about the HCI's racial equity work. HCI has for more than a year had a racial equity team. We're part of a learning collaborative of other state departments that are focusing on racial equity, and we start all of our learning collaborative meetings with a land acknowledgement statement, a Black liberation statement. So HCI has developed our own land acknowledgement, Black liberation statements, and equity statements. And I'm just gonna start by reading a portion of HCI's land acknowledgement statement this morning. The Department of Healthcare Access and Information, Sacramento and Los Angeles offices sit on land stolen from the Miwok, Nisenan, Chumash, and Gabrielino Tongva peoples. We acknowledge the resilience and fortitude of the Miwok, Nisenan, Chumash, Gabrielino Tongva, and other Native peoples who, despite efforts at genocide, survive as cultures and communities today. Cross-generational trauma, systemic racism, and historic discrimination have taken a toll on Native peoples, contributing to health disparities, a lack of access to healthcare services, and barriers for Native peoples to become part of the healthcare workforce. We commit to evaluating our efforts in these areas to advance justice, rectify past injustices, and ensure historic wrongs are not repeated. In solidarity and allyship with Native peoples, we commit to being positive catalysts for change, not culprits or passive witnesses of the injustices perpetuated throughout our history. We acknowledge inaction as the fuel that sustains inequity. We commit to using the demographic data we collect to illuminate disparities in health delivery systems and to disseminate actionable information to expose the lingering impacts of past actions against Native peoples and underserved communities. We commit to advancing our understanding of the tribal health delivery system and listening to tribal voices to guide us in eliminating barriers Native peoples face in becoming part of the health workforce and other barriers that prevent access to quality care. We commit to revisiting HCI's programs, policies, and procedures to allocate state resources equitably in a manner that recognizes our responsibility to address disparities. So I appreciate HCI's racial equity team members who developed that land acknowledgement. I now have a few slides I want to go over in terms of areas of authority before the board and the office. So this is meeting 3, of course, of this new healthcare affordability board, and we are still finding our way and communicating about different areas of authority. So as we've discussed, the statute does denote different roles for the board on different areas. So we are, in trying to communicate as clearly as possible, we will be using a yellow area for areas over which the office has decision-making authority that we're getting input from the board. So we'll go over in a minute the slides, and you all have seen these before, that the statute is very clear of areas where the board has ultimate decision-making authority, setting the cost targets, appointing the advisory committee and the like, and areas where the office is obligated under the statute to discuss or consult with the board. And so, of course, with all of those areas, it's important to get stakeholder input as well as input from all of you. And then the areas where the board has ultimate decision-making authority, we will have the green arrow. So moving on to slide 6, this indicates, again, the areas where the board has ultimate approval or establishment authority. Again, appointing the advisory committee, which we'll be doing, which you all will take action on, we anticipate shortly. Methodology for setting and modify the spending targets is another bolded area that we'll be discussing today. And then slides 7 and 8 are areas where we as an Office of Healthcare Affordability are required under the law to consult and discuss with the board, including some of the risk adjustment methodologies and equity adjustments, as well as the baseline report. So a lot of the areas that we discussed at the April board meeting were under this statewide capture of total healthcare expenditure for the baseline report. And those are areas that it's very helpful to get your input. So for example, on, do we include TRICARE? Do we include public health expenditures? What should the treatment of California residents getting care outside? Very helpful to get your input, the input of the public, and then ultimately the office will be promulgating regulations as to those matters. So with that, I will hand it over to Vishal Pagani, Deputy Director of OCA, to discuss some more follow-up items.
Thank you, Director Landsberg. So I'll first follow up on discussion from the April meeting related to THC measurement. I will then follow up on some updates to the board work plan. So in April, we received some considerations. We reviewed some considerations for defining, measuring, and reporting total healthcare expenditures on a statewide basis. OCA will collect and report THCE at the state level, including by market. Market includes Medi-Cal, Medicare, and commercial. So we'll do this in our public reports to track spending trends. So last month, board members expressed interest in accounting for other categories of spending, such as spending by the uninsured or cash payments for services by insured consumers, as well as other public spending on TRICARE, Indian Health Services, Veterans Health Administration, and county indigent services. OCA is continuing to research these and will return at a later board meeting for a more substantive update on the feasibility of reporting this spending. So the focus of including additional components and categories of spending, such as correctional health services or TRICARE, would be to have a comprehensive view of statewide spending and trends relative to the spending target. Do want to note that some categories of spend that make up the statewide total, for example, TRICARE, VHA, IHS, will not be subject to enforcement. It is really the payers, providers, which include physician organizations and hospitals and health systems and fully integrated delivery systems that are the statutorily defined healthcare entities subject to the spending targets. Does the board have any questions before I move on to board work plan updates?
Elizabeth.
Thank you. Just a clarification perhaps, but when you say you're going to track by market, will that enable sort of accountability at the organizational level, like the hospital or the system? Because there may be wide variation within the market.
Yeah, we've, in last month's meeting, we did have a diagram where it shows kind of the statewide kind of column, which is the highest level of reporting. But we would want to break it out by market. Market would be an aggregation of, within Medicare, there would be Medicare Advantage and Medicare fee-for-service. But then when you get to the carrier-specific reporting, which is, for example, a specific health plan, then we could attribute spending to particular providers, which could be physician organizations, health systems. So that's where we'll be actually going over this afternoon with Michael Bailett about the way we could take that payer aggregate THC data and attribute it to providers.
Other questions? Okay.
So moving on to the next slide of board work plan updates. Just want to call out a few changes we've made since the last time you've seen this document. For alternative payment models, primary care investment, and workforce stability, we've moved up this discussion to have it sooner. So it'll be taking place at the June board meeting. Next month, you'll receive an overview of our planning efforts and work to date. For cost and market impact reviews, which is OCA's program for assessing market consolidation, we provided a few more specifics. In June, we will share the date of an August regulations workshop for proposed text for CMIR regulations. Excuse me, I misstated that. In June, we will discuss the timeline for drafting and submitting the CMIR regulations. So in June, we'll walk you through kind of the staff work done to date and then that process to get it to the Office of Administrative Law. And in July, we will share the date of an August regulations workshop for the proposed regulations text. In August, we'll provide a status update on the proposed text and the comments we've received at the August rulemaking workshop. And then that last, the third bullet here for THCE, we've moved the submission of regulations from December of 2023 to January of 2024 to accommodate impacts from the holiday schedule in state offices. But we are moving as quickly as we can to work on that rulemaking package. Any questions from the board? Thank you.
Great. So we want to open it up. Public comment now, and then we are going to move into our action consent items.
We will now recognize members of the public for comment. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may line up at the podium. Those attending virtually who want to comment should click the raise hand button. Those dialing in can press *5 to raise your hand. It will track the order which the hands were raised. During the public comment, you'll be unmuted when it is your turn. We also invite you to provide written comment at oca@hchi.ca.gov. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. We have this time clock as a guide, and we'll note when speakers have 10 seconds left. We'll start with the individual at the podium.
Beth Capel on behalf of Health Access California. I'd like to begin by thanking the staff and the chair for the presentation we've just heard, clarifying what things are for action by the board and what things the board is discussing, and clearly identifying the action items from the discussion items, and a new category to me, the information items, where they are consulting with this board. We very much appreciate the response to our earlier concerns and consider it addressed. Thank you.
We'll now move to virtual public comment. We'll go in order that the hands were raised. Cindy Keltner, you are unmuted. And Cindy, you're unmuted on our end. You have to unmute on your end also.
Oh, sorry. Apologize. So just thank you for all of this work. Really appreciate the opportunity to listen in and to learn. And my only comment is that I hope that for the alternative payment models that you're coordinating with DHCS as they are getting ready to launch their first cohort of an APM in January of 2024. So just making sure that, you know, we're coordinating on all the different levels. Thank you.
Seeing no other in-room public comment, we'll go back to virtual public comment. Craig Simmons, you are unmuted. Please go ahead.
Hello, can you hear me?
We can.
Okay. So the plan is on total healthcare expenditures to have all of the data compiled by January 2024. Is that correct? If it is, my question is, what do you intend to do with all this data, assuming it's premiums and costs for outpatient services and prescription drugs and primary care, co-payments and the total healthcare expenditures? My question is, once this data is compiled, assuming it's January 2024, what is the plan beyond that until the November election?
Thank you for your public comment. And we'll take a person here at the front of the room. Welcome.
Good morning, everybody. Cesar Lara with the Monterey Bay Central Labor Council. We represent unions in Monterey and Santa Cruz County. Thank you for the report. Looking forward to future discussions. And the question that I would have is as we talk about equity across the state and with the work that you do, equity doesn't mean just a spread all over the state to make sure that everybody has a voice. But those communities that have been heavily impacted by healthcare should be one of the main discussion points as we talk about how we fix some of these issues across California. Because as you know, if we fix some of the hardest to address communities like in Monterey County, maybe we could actually fix the rest of the state. So thank you, and looking forward to the further discussions.
All right, moving to virtual public comment. Carrie Sanders, you're unmuted. Go ahead.
Hi, Carrie Sanders with CPEN. I just wanted to thank you for today's meeting, listening in for the first time, but I appreciate the conversations that you'll be having around healthcare expenditures, equity, and quality. And we look forward to engaging with you on these issues as you move forward, both in the advisory capacity and at these meetings more generally. So thank you.
All right, I see no additional in the room or virtual public comment.
Terrific, thank you. We're going to move into the consent calendar now. I just want to make one comment about public comment that we, as this board knows, many of you have been on many other boards like it. It's our chance to hear from the public their comments, and even though occasionally we do get a question here or there in those comments, we obviously hear it, but we don't take the time to respond to it in the public meetings, and that's tried and true tradition. But I wanted to explain that, both remind our board, but also to the public in how you frame your statement or comment as well. So moving into our consent calendar, just a reminder, this is often routine items that we do meeting to meeting, and generally don't expect them to be rich with lots of discussion or controversy per se. So today, with that truth, we have one item on our consent calendar, and that's the approval of the minutes from our last meeting. So I'll open it up to see if there are any concerns, edits, refinements from members of the board.
Move approval.
Great.
I'll second it, Mark.
Okay, let's do roll. Public comment before we go to roll. Seeing none in the room. Any online?
We now invite public comment for approval of the board meeting minutes. Seeing none online either.
Okay.
We'll now move to roll call. Secretary Galley.
Yay.
David Carlisle.
Here.
Dr. Sandra Hernandez.
Aye.
Richard Kronick.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
Dr. Richard Pan.
Aye. Aye.
Thank you.
Okay. So now moving into our next item around the advisory committee, and it's our first action item. CJ Howard, welcome, and thank you for walking us through where we've landed.
Thank you, Chair Galley. Good morning, members of the board, members of the public. As noted, my name is CJ Howard. I'm the Assistant Deputy Director over the Healthcare Spending Targets Branch. In April, the board established a subcommittee comprising board members Mitchell and Pan to work with OCA staff to present the board with a series of recommendations related to establishing and appointing members of the Healthcare Affordability Advisory Committee to ensure that the board is considering perspectives from a diverse array of stakeholders. Well, I'm sure it goes without saying, this was absolutely no small task. This morning, I will present a series of slides that encapsulates the subcommittee's deliberations and ultimate recommendations for the board's consideration. First, though, I'll start with a brief legislative background on the charge of the advisory committee and the board's charge when considering appointments to the advisory committee. All right. Wrong direction. All right. Okay, the advisory committee is charged with providing input and recommendations to the board on the following. I'll summarize: statewide and geographic and sector specific targets, target setting methodology, sector definitions, spending benchmarks, goal setting and adoption for APMs, quality and equity metrics, workforce standards, and others. There's quite a lag. I'm going to default to my least favorite method of presentation. Can somebody advance the slide for me? As a former teacher, I'm nothing without an overhead and some pens and some markings on my hands, if some of you will be able to harken back. All right. So enabling statute requires the board to establish the Healthcare Affordability Advisory Committee to provide the board with input and recommendations, and to appoint the members by a majority vote, and at least one member of the board to attend the advisory committee meetings. That's a note that I want you all to put a pin in because we'll come back to it later in the presentation today. When appointing members to the advisory committee, the board shall aim for broad representation from consumer and patient groups, payers, fully integrated delivery systems, hospitals, organized labor, healthcare workers, medical groups, physicians, and purchasers. When appointing members, the board must also consider the applicant's expertise in the following areas: healthcare economics, healthcare delivery, healthcare management or healthcare finance and administration, health plan administration and finance, healthcare technology, research and treatment innovations, competition in healthcare markets, primary care, behavioral health, purchasing or self-funded group healthcare coverage for employees, enhancing value and affordability of healthcare coverage, or organized labor that represents healthcare workers. Clearly, we did not find a unicorn that met all of these requirements. Statute also charges the board to consider diversity of expertise, the state's diversity in culture, race, ethnicity, sexual orientation, gender identity, and geography, and any experience as a patient or caregiver of a patient with a chronic condition, including behavioral health care or a disability. Okay, so that's the background, statutory background on the advisory committee. So with that framing in mind, I'm going to try to summarize more than 4 meetings, approximating more than 6 hours of discussions and deliberations, and countless hours of asynchronous document review. I'm sure there will be nuance that I failed to not fully address, so I welcome subcommittee members to weigh in and fill in any of the detail that I may inadvertently leave out. So in summary today, we'll take the first 4 items here kind of as one, and then the dangling Chad will be board member attendance at advisory committee meetings. We'll likely end up considering that slightly separately, but it goes back to that one board member must attend each advisory committee. So we'll likely spend the majority of our time on the first 4 bullet points. Okay. Wanted to take this as an opportunity to also just discuss, as part of our discussions for the optimal size of the subcommittee, we also did take into consideration and just wanted to call out the other avenues that do exist for the public to engage OCA and the board, including public comments at our monthly board meetings. We always submit comment letters to oca@hki.ca.gov. Advisory committee, both the membership, obviously what we're here to discuss more today, public comment at the advisory committee, those will all be meetings that are run in accordance with Bagley-Keene, and so those will be open meetings to the public for additional comment and input. And then also OCA will be convening various work groups to address such topics as primary care, alternative payment models, behavioral health, workforce stability, collection of payer data, and I'm sure others as we go through on this journey. I also want to note that OCA will be considering for membership in these OCA convened work groups, obviously some of the entities that may have applied for the advisory committee, but may not ultimately get appointed or selected. So taking those first 3 bullet points, and we'll try to summarize this as quickly as I can. We started with discussion around the ultimate size of the advisory committee landing on approximately 25, give or take. As noted, I'm a former educator or teacher. There's a huge difference in terms of, and not to say that the advisory committee will be a classroom, but there's a huge difference in participation between 22 people and what 22 students can do, or people in a room when they're discussing, and what, say, 70 people might be able to accomplish. We felt that 25 was an appropriate size that could allow for each individual appointed to the advisory committee to provide meaningful input, while also balancing that we want to have broad representation of different groups and different perspectives. The advisory committee, we also discussed in that vein terms, and we'll distinguish between terms and term limits. We felt that 2-year terms were appropriate, with no limit on the number of terms that any one person would be able to serve on the advisory committee. This allows the board for flexibility to pivot and incorporate diverse perspectives as needed, or as just the board's work evolves in the coming years, ensure that we're keeping up with the representation that the board feels that it needs to guide its work. And we would also recommend in that light that half of the initial appointments would serve a 1-year term. Those individuals that are selected would be selected randomly. We'll get more into that later on in the presentation. And then as far as, so how would the subcommittee recommend that the board go about considering appointments and reappointments? We would convene annually a subcommittee that would be charged with reviewing submissions of interest or applications for the subcommittee, and then come back annually to make recommendations to this body about who should be serving and filling those positions on the advisory committee. Okay. So those were the first 3 items, kind of a high-level synopsis of the discussions that we had, and move on to the committee structure. So the subcommittee found the statutorily prescribed categories useful in ensuring that there was broad representation across multiple sectors and include diverse perspectives, and came up with the following groupings. So there's some slight deviations from how they're enumerated in statute. But essentially we had payers and fully integrated delivery systems, hospitals, medical groups, physicians, healthcare workers, organized labor, patient and consumer groups, and purchasers. You'll note that all of them, with the exception of patient and consumer groups, to ensure that we had an adequate voice from that sector, have an equal number of representatives. The subcommittee also sought a degree of parity or balance between individuals that are subject to the spending targets and those that would not be subject to the spending targets. While there's a little bit of ambiguity in there, essentially the breakdown of this is 35% of the makeup would be from payers, hospitals, and medical groups. 42% would be purchasers, organized labor, and patient and consumer advocate groups, and then 23% would be physicians and healthcare workers, for a total there of 26, not 25, so approximately 25. I see there's a question.
A quick question. You said there was some slight deviation from the statute. Could you elaborate on that?
Yeah, so fully integrated delivery systems are called out separately from payers in the statute, so we combined payers and fully integrated delivery systems. The fully integrated delivery system, as I understand it in statute, refers to Kaiser. So going a layer deeper into this, as the subcommittee sought certain attributes that it wanted to see represented within each of these categories. In some case, and this is a non-exhaustive list, we certainly went a little bit deeper in certain areas, but I think these were the attributes or criteria that we were looking for people to fill in roles for them to fill within these categories that were driven largely by statute. So we were looking for statewide plans, individual within the payers and fully integrated delivery systems. We were looking for statewide plans, individual markets, Medi-Cal plan, regional plan, fully integrated delivery systems, and nonprofit health plans. Within the hospitals, we were looking for safety net, large systems, teaching or academic, and standalone hospitals. Within the medical groups, we were looking for IPAs, primary care and family medicine, capitated risk-bearing organizations, Medi-Cal providers. Within physicians, primary care physicians, specialists, rural providers, safety net providers, and behavioral health providers. Then the healthcare workers, we're looking for frontline perspective, safety net or FQHC, behavioral health, care coordination, and social drivers or social determinants of health perspectives. Kind of recircle back to that in a moment. Within organized labor, we were looking for people that could represent healthcare workers, administers benefits, and negotiates with employers for benefits. Within the patient and consumer groups, we're looking for the consumer perspective, diversity of communities and people represented, disability groups, children's perspective, tribal representation, elderly perspective, and behavioral health and consumer perspective. And then within purchasers, self-insured trusts, large purchasers, and self-insured private employers. This is a great stopping point.
This is Richard Pan. I have my hand up.
Go ahead, Richard.
Yeah, no, I appreciate that. One of the things for the board, I just want to mention, and certainly Elizabeth can also comment on this, is that while we're sort of discussing, in this framework, of course, as outlined in statute, I think as we reviewed the applicants themselves, I think I want to distinguish the applicants from the categories. We are looking for people who brought in a variety of different things. So, you may see when we finally present the names, and I think, people have had a chance to see the slides, you see people perhaps in different, what appears to be different buckets. But as we were looking at, people, we're looking at individuals as well, right? So we're looking at them as individuals as well as, the fact that maybe in their current role, they are in a, hospital, or they're a patient consumer group, or they're, labor or something. So I just want to mention that the nominees go beyond simply, we had 3 people in this bucket or 5 people in that bucket. Is that we actually, try to delve into a little more of information that they provide in their application about other types of experiences and things that they brought to that, not just what their current job title is or their current job.
Yeah, thank you for adding in. As I said, please make sure there's a lot of nuance to our deliberation. So happy for that perspective to be shared. I do want to share 2 more things on that previous slide if we can. One, you'll note when we get to the proposed membership, we did not identify an individual in the healthcare worker space that really met the subcommittee's desire for somebody that can meet the care coordinator, social drivers of health perspective, an example of which may be a social worker. So you'll see that slot's held open. And then we didn't find in the patient or consumer group somebody who was really explicitly a behavioral health consumer perspective. The subcommittee was it thinks that should be a priority to be filled through subsequent turnover within the advisory committee. So we'll just put a pin in those 2 items for now. So if we could advance, and to kind of, I think Dr. Pan more eloquently put this than my series of bullet points, but this is really, so then when we started with the structure, the attributes that we were looking at, and then it was, okay, so now we need to identify individuals. So that's sort of kind of like getting deeper and deeper into the ultimate proposed membership. The subcommittee, we reviewed more than 130 submissions, and when we were looking at individuals, we were looking at the diversity of their professional experiences, we were looking at the breadth and the depth of the submitted responses, we were looking for individuals currently working in the industry they represent, and so bias towards that. And then individuals with lived experiences within the healthcare system, and individuals that were reflective of California's diversity in culture, race, ethnicity, sexual orientation, gender identity, and geography. So this is kind of, we started high level what the statute prescribed. How did we try to operationalize this into some sort of analytical construct to sort through the 130 applications and then get down into the individuals? I'm not going to read this slide, but this is representative of the different professional experiences that people indicated having experience with in their applications of the proposed membership. So that you can see that there's lots of individuals expressed that they had experience or expertise with enhancing the value and affordability of healthcare coverage, the charge of this board. And from there, you can see of the 25 currently proposed members, how they fall out in terms of the professional experiences that they bring to the table. And that's all self-reported data. So the grand unveiling, if you will, is the proposed advisory committee membership. I will take a moment to at least read into the record the the individuals, each of their names, and the groups within which, at least from that analytical construct that I described, each would be categorized under. And while I certainly will do my best to pronounce each person's name, I sincerely apologize ahead of time if I mispronounce anyone's name. So within payers and FIDS, we have Eliza Arjoyan from Blue Shield of California. In payers and FIDS, we have Yolanda Richardson from the San Francisco Health Plan and Andrew C. from the Kaiser Health Foundation Health Plan. Within hospitals, Barry Arbuckle from Memorial Care Health System, Tam Ma from UC Health, Yvonne Wagner from San Bernardino Mountains Community Hospital. Then medical groups, Hector Flores from Family Care Specialist Medical Group, Stacy Herantis from Sharp Reese Steely Medical Centers, David Joyner from Hill Physicians Medical Group. Within physicians, we have Parker Duncan Diaz from Santa Rosa Community Health, Adam Doherty from Vituity, Sumana Reddy from Acacia Family Medical Group. In the healthcare workers, we have Sandra Paisano from Altamed, Carrie Ann Wabrew from FuseCore, and then this is where we recommend, the subcommittee would recommend holding open a slot for the care coordination and social determinants or drivers of health perspective, and we would come back a month from now after doing some more outreach to fill that slot. Within organized labor, Joan Allen of SEIU, UHW, Carmen Komsty of California Nurses Association, Ivana Krejcinovich from Unite Here Health, Carolyn Nava, so that was in organized labor. Then the patient groups and consumer advocates, Carolyn Nava from the Disability Action Center, Mike O'Day from Children Now, Kieran Savage Sanguin from California Pan-Ethnic Health Network, Renee Williams from United American Indian Involvement, Anthony Wright from Health Access California. Within the purchasers, Ken Stewart from California Healthcare Coalition, Suzanne Usage, The Wonderful Company, Abby Gant, San Francisco Health Service System. The proposed AC does have a balanced gender and sex profile. The proposed AC has a broad racial and ethnic representation from many non-whites and people of color, and the proposed advisory AC or advisory committee has broad geographic representation spanning from the south to the far north and rural and urban parts of California. And so, the draft motion from the subcommittee would be to approve the proposed advisory committee membership totaling 25 individuals currently, appoint the members for 2-year term, and permit OCA staff to randomly assign half of the slate to a 1-year term while ensuring that at least one member from each category serves a 2-year term, continue to receive and review submissions, and subsequently incorporate a care coordination and social determinants of health perspective onto the advisory committee, and solicit applications for appointment to the advisory committee annually between January and March. And with that, I've talked for way too long. Thank you for tolerating me, and I'll leave it to you all for discussion.
CJ, thank you for just your time today and the time and work with our subcommittee. To Richard and Elizabeth, thank you. You stepped up a month ago, and we appreciate the work over the last many weeks. So with that, happy to open it up to questions. See Ian's hand up. Go ahead, Ian.
Thank you. And first, I want to acknowledge they did step up, but they were also thrown under the bus, Dr. Pan and Elizabeth. And I want to express my deep appreciation for the huge amount of work you put in, and acknowledge that the favor will probably be returned someday. I did want to, scrolling back to I think it was the second slide, note that there was a paraphrasing in the language about the charge in the statutory language. The statute actually says that the board shall aim for broad representation, including at a minimum representatives of the groups that we have laid out here. And I would ask that in lieu of this motion, we accept this motion, but that we hold back the 2 nominees identified as healthcare workers here, and acknowledge that the 2 representatives categorized as organized labor here from SEIU and from CNA are representatives of healthcare workers. You know, just to be clear, I have no quibble with the expertise or qualifications of Ms. Pisano or Wabrew. But I can't, in good conscience, support categorizing management or administrative personnel as representatives of workers. And I think in the statute, we'll find that there's reason that we split representatives of healthcare workers from representatives of organized labor more generally. They're very different interests, sometimes conflicting interests. And I do think we need much broader representation under organized labor in particular, organized labor bargains for the money that funds 35% or so of employer-sponsored healthcare in the state. They're also profoundly impacted by decisions around capital expenditures and other things. So I would like to see a representative from the public sector in that category as well. And so I really, again, appreciate the attempt to strike balance here, but I think we failed in this category, and I would like to see that balance corrected.
Great, Ian, I want to make sure before I ask you to restate the change to the motion, if there's questions from any of the colleagues on the board, specifically to Ian's question first, so that we can.
Well, maybe if I could, Mr. Chair, anybody from the subcommittee, oftentimes people come with that background in representing labor and then move into a management role. So the question I would have is, in the experience of that applicant, who I don't know, but in the experience of that applicant, is that part of the experience that she put forth in her proposal? Because if so, I think it's valuable to have both of those perspectives potentially. So that would be the only addendum I would make to Ian's comment.
Given this may be a question, CJ, you can help illuminate. If not, it may be may not be information at the tip of people's right.
I did try to pencil all 130 to the top of my brain, but I think we can pull up if you want us to.
We don't need to do that in the moment, but I think if we had an answer, great. If not, I'm aware that we may raise a few questions here that leave us hungry for a little bit more, and that's why, Ian, your suggestion may be the prudent one, that we look to modify what we approved today and prepared to continue to kick the tires on parts of this down the road. Before we move into other questions, Richard Pan, Dr. Pan, is there anything I want to make sure that I am deferential to both you and Elizabeth if there are any comments or suggestions to the questions our fellow board members have on this. Elizabeth, for now, we can, okay. And Richard, I want to make sure that you have a chance. Your hand is up, I see. So maybe that is a response to Ian's question. And if it is, great, we'll take it now.
Actually, it's a response to Sandra's question, comment.
Okay, so before we go to that, Richard, Ian, could you restate how you are proposing we amend the motion that had been shared?
As concisely as I can, I'd ask that we accept the staff's draft motion with the exception of Sandra Pisano and Carrie-Ann Webru, and that we ask staff to go back and reapportion Joan Allen and Carmen Comsty as healthcare workers, representatives of healthcare workers, and do their best to fill out the balance of organized labor.
Okay, Elizabeth, go ahead.
Just a clarifying question. So you're suggesting that those two be added to this category, and then there's two openings on the organized labor?
Yes, that's my intent.
Okay, just to restate it, move Joan and Carmen to the healthcare workers category to replace Sandra and Carrie-Ann, and then determine two additional members or additional members, I don't want to stipulate the number, in the organized labor category. Okay.
So I just want
yes, please.
So we're proposing that Sandra and Carrie Ann not move forward.
I believe that's what Ian is suggesting.
That's my suggestion now. My feeling is if staff want to come back and put them in another category, again, trying to preserve the balance, I'd be open to that conversation at the next meeting.
Yeah, I would certainly feel a bit more comfortable there, not knowing either candidate myself. So without prejudice, just wanting to make sure that we don't jump to a conclusion about their expertise and their contribution, but appreciate the main point that you're making, Ian. We'll paraphrase or hopefully get it right, is that we want to make sure that those in each of these categories actually represent those categories well. Okay, so with that edit caveat, let's table it for a second and then maybe go, Sandra, to you asked a different question. Richard, you were prepared to jump in on that, so I want to yield the floor to you to comment on Sandra's question, and then also any other comments you'd like to make.
Sure. Yes. So, and again, I appreciate if my co-member also, if she wishes to comment as well in terms of our discussion. I think one of the things as we were looking at appointees, that includes the healthcare worker group, and actually, frankly, a lot of the other groups, is that we did lean toward people who actually, I would say, did the work on the front lines. So not simply a representative, but in the work, who actually was more on the front lines doing the work. I would make mention that as far as the healthcare workers, one of the things we did want someone who specifically behavioral health, someone who did have some experience doing that frontline work. I appreciate Sandra's comments about, we did look at whether they had that previous experience. There were several candidates for consideration, but I guess there's a slightly different interpretation. And again, it's up to this board to decide. In the healthcare worker space, and frankly, as we looked at many of the other spaces, we really look for people who actually had direct experience doing the work, like they were actually a healthcare worker, not simply a representative. And I think this is something we confronted in other categories as well when we look at nominees in terms of having people who actually had to actually be doing sort of the work or the function, right, of that, not just representing people who did that. So and again, that's the lens through which you looked at, and certainly it's up to this board to decide whether they think that lens should be the one that the whole board wants to use as well. And actually, I guess I would see if Elizabeth also would have any comments as my co-member on this committee.
Thank you, Richard. Elizabeth is shaking her head, so nothing to add to what you said, but just to make sure, summarize again your comment, the objective in the healthcare worker category was to identify, I'm going to say because physicians have a different category themselves, other healthcare workers with both frontline experience to represent the voice of those other frontline workers and not necessarily the organization of healthcare workers themselves. So this was really leaning on clinical experience and expertise in delivering healthcare rather than the objective of organizing healthcare. I want to make sure that I'm not inappropriately or incorrectly characterizing your point, Richard. So if you could confirm or restate.
Yes, I think you
Okay.
got that accurately. And again, the reason I just the reason I was also asking Elizabeth to comment, and of course you can choose to or not, is that was something that we both used in terms of the lens in which we looked at evaluating the nominees. But I just want to be sure she was also in agreement with what I said.
She is going to jump in. Go ahead, Elizabeth.
Thank you, Dr. Pan. Yes, that was our general approach. The only thing I would add is that in the healthcare worker category, we were also specifically looking for someone with behavioral health expertise. And there was sort of a limited number of applicants. So I just would say that having a balance in sort of realms of healthcare work, that was one of our goals, to have behavioral health clearly represented.
Got it. Thank you for that clarification. I saw David's hand up, and then we'll go to you, Rick.
Yes, just a quick question, and without going into specifics, I want to focus again on the diversity criteria and make sure that we're contemplating that consideration here. I don't know either Paisano or Waybrew, but I want to make sure that we don't have any N of 1 categories that we might be excluding with the proposal.
Good, important question. I don't know if CJ, you want to respond, and or Richard or Elizabeth.
I wouldn't be able to answer that with what I have in front of me.
Got it. Yeah.
There was some limited information about some of those questions.
Yeah, I'll just jump in. The application did kind of ask people for a personal statement, including diversity, and I think at least one of the candidates did talk about having a single immigrant mother and her personal experiences with caregiving. So we certainly took all that into consideration.
And the diversity categories still remain well represented with the current proposed slate.
Yeah. Again, I think as CJ noted, we'd want to go back and look at it. And if the board were to move forward without some of these applicants, that would certainly be taken into consideration if there were new applicants considered.
Sandra, is your point relevant to David's question before we move to Rick's? No? Okay. So Rick, I'll go to you next.
Thank you. And, I add my thanks to Elizabeth and Richard and CJ and the work that went into this. You can only imagine what it took. And having said that, I was confused particularly by the nomination of Sandra Pisano as a healthcare worker. And Elizabeth, you mentioned the behavioral health interest, and that may be kind of the main part of the answer. But Ms. Pisano, who I don't know and who looks like a very talented person, in your application, when she was asked to list, the category or categories, she listed fully integrated delivery systems and not healthcare worker, and then describes, her work as the director of behavioral health at Altamed for 12 years. I'm responsible for overseeing, managing, and administering the behavioral health budget, responsible to practice cost-effective methods to successfully manage the budget and keep the department efficient and productive. I oversee several HRSA and SAMHSA grants. And that does, when I read that, it's like, how does this fit with healthcare worker? And I imagine there was, something in mind to put her there, but she didn't self-identify as a representative of healthcare workers. And I wondered kind of what the thinking was.
If you'd like, Elizabeth or Richard, jump in. Yeah.
I'll invite Richard as well. It was really the behavioral health angle, but I don't disagree. And there were some gaps in the applicant pool, but that does, it really is a board decision, but would agree with your assessment.
Richard, any other feedback on this question from Rick?
Yeah, I think that our priority was to identify someone with that behavioral health background. We did consider several applicants. I think she also brought in some additional personal experience as well. But I think in terms of the healthcare worker, I hear Ian's concern in terms of, well, maybe we do have generally people who now have moved on to management. Maybe we might want to step back and try to solicit more people who are on the front lines in terms of their their experience. So I think so. In the same way, we kind of held open we didn't really find someone who fit these coordination care piece, you know, maybe what we need to do is more targeted, I guess, solicitation in that regard. I guess, I think part of the question for the board is going to be, is that the direction you want to go with the healthcare worker space, right? You're saying, okay, what do we want there, and also what kind of, you know, maybe we need to relook at the nominees in that space or not, right? Or do we, you know, basically shift over? So anyway, so I think that's something for the board to consider, you know, to decide here.
Great. Yeah, I think that's certainly what's in front of us, given Ian's amendment to the motion. Elizabeth.
I just wanted to add that there was a process step sort of midway through where we did a second solicitation for applicants, particularly for behavioral health. So I think we could do that again. And as Richard said, there's a precedent here for holding something open when we didn't have sort of the profile that we were looking for. So I'd be supportive.
Great. Good. Ian. Next.
Yeah, I don't want to, I do believe that this understanding that small class size is helpful, but this can evolve a little over the coming weeks. I do want to push back on the question of who represents healthcare workers, though. I mean, healthcare workers as a collective have the most at stake in limiting spending in this state, and the institutional representatives of that class of workers need to be represented distinctly from the more general category of organized labor, who fight tooth and nail to fund the funds and the trusts that pay the purchasers, or who are the purchasers. Those are really two different categories. And I think Joan and Carmen are two excellent examples of representatives of healthcare workers, because they are held to account institutionally to represent those workers. So I, again, don't diminish the value, certainly, of frontline experience, and I want to keep pushing for that. But they are institutional representatives, and we should acknowledge that.
Yeah, I'll just say, I think, Ian, you're identifying two categories, and I think the subcommittee was almost seeking a third, which was that frontline experience. So you really talk about organized labor, you talk about the coalescence of the concerns of healthcare workers sort of generally as a group, and then there's the experience of frontline healthcare workers that one could argue, all three are really important to this conversation and the work. So as we think about your amendment to the motion, I think we should, personally, I think, consider both how we approach organized labor, how we approached healthcare workers, and not simply shift folks from one category to the other. Based on today's conversation, I think we should spend a minute being a bit more thoughtful about how we think about both of those. So if we're going to leave it open, certainly as we come to a refined motion, I will ask us to consider that piece. But before we do, Sandra, go ahead.
That was essentially the point I wanted to make, Mark, that what we're sort of talking about is what is the dimension of the particular categories. And I think, Ian, you had a different view than the subcommittee did. I think direct healthcare workers is a super important perspective, notwithstanding anything you said, which I completely agree with on organized labor. And so I would prefer that we have the top line conversation first about how do we think about the definition of those categories, and then figure out what we do with either holding positions open or moving people. Suggestion to the chair.
Yeah, no, I think it's a good one. I'll just add a slightly different comment, just for the record, really, that the care coordination and social drivers of health bucketing together probably wouldn't be the way I would sort of connect those. I mean, they are related, but I'd be curious how we bundled those together, and if it's worth, as we consider our future filling of that bucket, if it is in fact two different individuals. I know we're sort of not loose, but focused on a number around 25, but that would be another amendment for consideration.
I will tell you that Origin was for a social worker, someone who was experienced in navigating affordability challenges, access challenges. But certainly it could be more than one because it's very important in our view.
Okay, Don.
I just in sort of agreement with the holding open until we find the right person. If there is a specific person or representative that we feel is missing, there is absolutely no harm in us going out and finding said person. And I'm sure that said person exists in California. So it's, it sounds like you guys were doing a lot of complicated three-dimensional chess-like activities, yes, and deeply appreciate that, but it's also fine for us to say this is the expertise we need and either put out a solicitation for that specific expertise to add a person or nominating. I don't know whether we can nominate, but I couldn't imagine we couldn't.
Yeah, certainly. I mean, targeted outreach is not. There you go. Right. Yes. Rick, go ahead.
Agree with both what you and Don said, but I'm not sure why that open slot or slots is under the healthcare workers column other than the three-dimensional chess problem, but I'm not sure it's a good solution to the three-dimensional chess problem.
I wasn't suggesting we leave it there. I was suggesting we just add it. I mean, we can add our own categories.
Yeah,
if we
yes. But not require that person be also a healthcare worker.
Right. That's, I think the focus on folks with that experience either directly or from a management. I mean, there's a lot of different ways to look at it, but I think it's key. And my only point is they don't necessarily have to go together. Care coordination in a strictly clinical environment, if you will, rather than the social, connecting the dots around some of the social drivers along with the clinical elements, they can look very, very different. And I think the expertise and frankly where California is driving with our view on social drivers and its importance, I think it does actually deserve some separate consideration from the classic care coordination that you might think is related to complex care management for people with multiple diagnoses, et cetera. So, all right, I want to make sure, Richard, okay, see your hand up again. Let's go back to you.
Yeah, I guess just keep in mind that the quote categories, and we weren't trying to fill a particular quota with each category, but we were doing this in the framework of we didn't want the group to get larger than essentially the mid-20s. So we kind of landed on 25 and then decided, well, we want that perspective. So we ended up at 26. We didn't really want to push it up toward, 27, 28, 30, 29, 30. So the categories are there because they're kind of outlined in statute. But again, as I want to just mention, we weren't sitting there trying to fill buckets, right? And in fact, as we were looking at applicants, that's why I was made the comment that we were also looking at as individuals. And so without citing any particular candidate, many of the candidates brought things beyond just what their current job title and so forth are. So, whether you want to count the social determinants of health coordination care as a healthcare worker or just say it's something else because it's not actually, there's no explicit definition statute, that's fine. But I would also say that let's not start growing this advisory committee to a much larger size because then we start getting some other issues as we look at, we call it the three-dimensional chess or whatever. And I do think that, we do explicitly want at least some frontline healthcare workers. I guess that's the, so hopefully, and that category was explicitly in the statute. So I think as we are deliberating, I agree that there's different ways of looking at things, but I just want to sort of reframe, what the larger frame the subcommittee looked at, and so as we're going out and let's say doing another, targeted solicitation that in terms of the number of positions and so forth, we're not greatly trying to expand the advisory committee in terms of size so that it can function. And I think again, another reminder is that the advisory committee is a public committee, so So it's great to be actually on it. It advises us, so we still make the final decision. But it also, there's public comment in the advisory committee as well. So organizations can comment both to the advisory committee and to us. There are other venues for which people can try to participate as well.
Great. Richard, thank you. Sandra, go ahead.
I just wanted to come back to that point about multiple points of input to the board and maybe ask staff to talk a little bit about how they see the working groups operating versus the formal advisory committee that we appoint. Because as I understood, CJ, we're thinking about working groups in behavioral health, for example. And so how would you form those, and what's your thinking about how they would work vis-a-vis how the advisory committee would work?
So the OCA convened work groups are going to be delving into details around data and definitions in the weeds in terms of, for example, for primary care spend, what are the procedure codes, what are the settings in which primary care takes place, and who are the providers. So they're going to be very technical versus the advisory committee is going to be more a little higher level and strategic and policy oriented and approaching it from that lens. Any work products that OCA develops using input from any OCA convened advisory committee or technical work groups would eventually be shared with the advisory committee and the board. But there is a little differentiation in terms of the getting into the weeds and the technical details in the department convened work groups.
I certainly agree with everything Vishal said, and maybe one way to look at it is that the technical work groups are advising the office on very technical things where we have to adopt regulations and the like, whereas the advisory committee really was developed to advise this board about, as Vishal said, larger strategic matters, partly because of the pretty strict conflict of interest provisions that didn't allow folks who are currently paid by healthcare entities that are regulated to be on the board itself.
Go ahead, Elizabeth.
And on this same topic, could you speak to how the technical advisory committees are being formed and selected? Will specifically sort of applicants for the advisory board, if and how they would be considered?
We're thinking of any submissions that don't get nominated or approved for the advisory committee, that there would be a pool of stakeholders, experts in various areas that we could draw upon. So we'll definitely consider them for OCA convened or department convened work groups. So it'll be a resource for the office. But some of the work groups are currently we're actively planning for, such as the primary care APM work group. So we were coordinating with regard to who got proposed for the advisory committee membership to make sure there's not any overlap. But any individuals can be considered that don't make it to this advisory committee.
It does seem like they're quite different roles, however, just to be really clear that maybe the expertise or the experience that makes you a great advisory committee member is different from what would on the working group. So certainly see the difference there. Sandra, I want to make sure that as you asked the question, we answered it in a way that allows you to form sort of the opinion on what we should do next for you.
On the advisory?
Just the toggling between the working group, the advisor, and just understanding the
spirit was really trying to get at this question about how the office thinks about the work groups, what role they play versus an open meeting format where people have certain rules that they have to abide by to be members of the advisory committee. And so I just wanted to acknowledge that there's complexity there. And even if people think about where they could add most value, that's something that those folks are also obviously actively considering as well. So I just wanted to have some
Yeah.
transparency to that.
And sort of to say a piece of it, maybe that I believe all of us were thinking is, in my view, the behavioral health focused working group does not replace a representative with behavioral health understanding, background, experience on the advisory committee. So continuing to search for that feels like a priority. Ian?
Just on that point, I know it's a challenge to find the perfect people for these categories. On behavioral health, I do think as much as possible, seeking out people with experience in private practice and the dynamics that cause such a huge portion of the workforce to fall out of insured care is, we're going to be well served to find those if any come forward, and I'll cross my fingers for that.
Okay, seeing Richard, your hand isn't up now. Seeing no more hands here. Oh, Don, go ahead. Yeah.
And the rest of the HCI staff who put this together, it is a thankless job, and you guys did a really nice job of it. Couple of questions. So it was helpful to hear you talk about the technical working groups, and I think partially answered or addressed a concern I had. But one thing that just seemed sort of missing from this group were folks who go deep in health economics, health policy, so academic types are what I'm thinking about. And one of the things that, you know, I think we would hope to get out of the advisory group is somebody who has been working on this set of problems for their entire life, and not from the perspective of a hospital or a union or any particular perspective, but from a more academic perspective. And there are a handful of really talented academics on the larger list who didn't make it here. There's also a really good actuary, John Burtko, who was at Covered, who seems like an opportunity. But I get that some of those folks get plugged into the technical working groups, but it would also be nice to have that voice in the advisory group. So that's thought number one. Thought number two, which is marginally more proprietary, is that the vice chair of the health committee of our state retiree group was on this slate. He did not make it in. I think the perspective of retirees is missing here, one, and I think folks who receive their benefits from a public source in retirement, also a bunch of funky, complicated issues. And if there is room for another consumer voice, and I generally think there's always room for just one more consumer voice, I think that would be one worth consideration.
Elizabeth.
Thank you. And I actually agree with Don's points. We had a couple of very strong sort of academic candidates that were on the list for quite some time. This reflects a compromise, and there was an interest in keeping it small, but I do think that there were some impartial, highly experienced potential other category folks. And again, on the retiree perspective, I would agree that that is an omission.
Okay, I want to be really sensitive to Richard Pan's point about size, because what I'm feeling, when you look at our list, we have two categories. Just to summarize a bit, we have 8 categories here. We have essentially started in with you putting on the table that 2 of our categories, I know you wanted a shift. I'm going to amend that a little bit and say, let's leave both of them for consideration so we get it right. So then one approach to this is out of the 8 to prove 6 of the categories. The hesitation about the amendment of the motion that way is to accommodate Don, and then Elizabeth, your support of Don's point that maybe we are missing, I'm just going to put it in another, it could deserve its own category. And then suddenly we find ourselves at closer to 30 rather than 25. And especially to Elizabeth and Richard, if we were to go in that direction and be open, if you went into this whole exercise with CJ thinking, oh, we're going to do 30 instead of 25, it might have shaken out very differently. And I want to, if we're going to go in that direction, because you did the thankless job of organizing a really hard list of probably very, very talented people across the board, how do you feel if we toggled somewhere between 25 and 30 on this rather than really anchor it to that 25, 26 number? Yeah, you and Richard, I mean, I think it's really important given the time you've put in and the thoughtfulness thoughtful approach.
I think there was commitment to keeping it under 30. I'm not sure, 25 to 29 is a huge difference.
Yeah.
I don't know if Richard agrees.
Richard.
Well, actually, we had a discussion, and we did that before we started looking at anybody. So this is agnostic to whoever else, and we looked at it and we said mid-20s, right? In fact, and we aimed at 25. I recall we even had a discussion that 30 was, like upper 20s to 30 was probably too much. So, and I think we ended up squeezing the 26 because we said, okay, we had an agreement about wanting to get that. So we sort of went from 25 to 26, but I was very explicit about really trying to stay around that 25, 26 zone. And in fact, we've talked about other voices in all the categories, including voices in the consumer patient. So for example, we said, and we even solicited for behavioral health voice, right? More explicit behavioral health. So that's mental health, substance use disorder into the patient, et cetera. And decided not to because we were already at 5. In fact, that's why we gave that increased voice to the consumer patient groups there. So, I think that we want to have a working subcommittee. I would point out that also, we thought carefully about the researcher end, so I appreciate Don's comment. There's nothing that prevents the advisory committee from having researchers, present to them the same way we're having researchers present to us as a board too, right? So someone who's a former academic, certainly value researchers and their perspective. I think what we're trying to do is figure out the composition of the advisory committee. The advisory committee itself can solicit additional input, can have people present, et cetera. Like researchers who certainly I think they bring something valuable to the discussion. But the question is that do they actually have to be members to provide that input? And we really, again, we're trying to lean toward people who had more frontline experience. So I admit we started off by saying how many should we have, in fact, and worked from there. And so I am concerned that we're starting to push number upward, and so and the problem is we're now looking at individual things, and it's always say, oh, it's nice to have that, it's nice to have that, right? And there's nice to have a lot of different things, but if we're going to have a board that's at the appropriate size to function optimally, I think that's where we started the conversation. And so obviously it's up to all of you to decide, all of us to decide, I should say. But that is, we started that agnostically, and just a little concerned that we're pushing the number up without sort of stepping back and look at everybody and everything. And we have lots of different quote missing voices, but we had to prioritize those, and that's why we looked at individuals and looked at what they could bring in, multiple different angles, right, as well. And so I mean, I think that's kind of the hard work that we were doing, was looking, sort of delving into not just everybody as categories, but people as individuals.
Thanks, Richard. That's, I think, really helpful to hear. And again, just want to reiterate the thanks to you and Elizabeth for just coming in, trying to set up a framework, and then going through the 130 plus applications. We know it's easy to imagine this or that. So I think the spirit of the conversation is more about making sure we do the best we can to get it right. But I appreciate the anchor to the size and commitment to that piece. Other questions or feedback from Sandra?
Well, I didn't go on the record, but I do want to thank the subcommittee. Ridiculously hard work, and really appreciate all the intentionality that went into it. I'm super appreciative. The only other comment I was going to offer is that it's rare when you have a committee of this size that everybody shows up to a meeting anyways. And so if you go to 26 or 27 or 28, I think functionally you'll end up with a group that should be able to give us adequate feedback and have adequate participation. So it's just another thought.
So I'm going to try to do the not impossible test. It's not nearly as hard as the test that Elizabeth and Richard just went through, but to suggest a modification to the motion that has been presented, that we approve the proposed advisory committee membership in 6 of our 8 categories, which is progress, totaling 20 individuals. That's would be the amendment to bullet 1. Bullet 2 would remain the same. Bullet 3 would be continue to receive and review submissions and subsequently incorporate individuals assigned to the healthcare workers category. And we may even want to amend that to frontline healthcare workers category. We can debate that as well. And the organized labor category. And then allow the subcommittee to consider any other thoughts about others that were suggested by members of the committee. So that would be a clunky 3rd bullet. And then the 4th one stands, solicit applications for appointment to the advisory committee annually between January and March. All right, that was a B- attempt at trying to capture it. B plot thing, all right, still. Yeah.
Did I hear in that we would keep meeting the subcommittee?
Well, I did say that only because I think the considerations around, especially these 2 categories, we could consider doing it in a different way. But yes, that was my proposal. Understanding that I'm not one of the subcommittee members. Yes, go ahead, Richard.
Yeah. Actually, one of the things I'm concerned about is that as we're soliciting more members, the subcommittee will, I think our first meeting is scheduled for June, right? And so I guess my question is that I hear that this issue around the healthcare workers. I also hear there's maybe some discussion about, whether we want to move some of the labor people to the healthcare worker or not, et cetera. But I haven't heard that people said, well, the existing labor nominees, people had problems with, right? Now, maybe maybe people would want to have more or move one over so there's more, et cetera. But at least the ones there are seem to be fine. And I'm just concerned that if we actually take out both, if we don't approve the labor representative, the people who we've nominated for sort of the labor bucket, for those 3 individuals, again, we're trying to nominate individuals, not organizations, that voice at least will be missing for the initial meetings of the advisory committee. And unless there's a problem people have with those 3, I would suggest we move them forward if we want to, do a little bucket shifting or whatever. But I mean, at least in the sort of universe of things, we looked at them both, their roles, but also as individuals. I would suggest they stay and that we approve them. And it's the healthcare worker space is the place where we're like, oh, we're not sure these are the right people, blah, blah. We want to do more solicitation. And those would be the vacancies we hold open. Hello.
So hear that point. I'm going to turn to you, Ian, and just what I heard from Ian is the move of 2 of those 3 members to the healthcare worker bucket, in part to create space for others in the organized labor bucket to be added. So it does matter where we sort of put folks. And my question is, from a frontline healthcare workers priority, are the 2 individuals that are suggested to be moved over the representatives the subcommittee would have picked to really represent that role? And I'm just not sure that's the case. That's why I hesitate just approving the names in one bucket or the other, because from, at least if I understood, Ian, your concern, part of it is to make sure that those who represent organized labor are folks that we believe carry that responsibility well.
Yeah, I appreciate Richard's and support Richard's suggestion to approve the people listed here under organized labor. Maybe in order to move forward, we hold off on the 2 that are listed under healthcare workers. I have deep compassion for Richard and Elizabeth because we haven't given them much clarity. We have slightly different interpretations of what these buckets mean. Frontline behavioral health workers, for instance, many thousands of them work for medical groups and could arguably fall under that category. Maybe, given the tenor of this discussion, the subcommittee, if it would meet again, could revisit and try and balance this out with more frontline healthcare workers, regardless of where the category is. And I also would implore them to look at balancing out what is currently listed as organized labor, so there's more representation of the broader group of organized labor.
Please.
It's not just balance across these committees, it's those subject to the limits versus those not. And I heard CJ say that they perceive balance. I'm not sure we're totally aligned, but I would say that I'm open to approving whichever. This is up to the board, obviously, but maybe if we held something open, it's a bit more flexible. It might not be just a category.
Okay. So I think one question, I think a decision point is, if Richard, I understood your suggestion that Ian seems to support, is to also approve at least some of the names in the organized labor category, which I again will share concern around, not because of the individuals, but because if we want to achieve that balance and make sure we have some representative voice, I mean, if you look at the other categories, they generally have 3 people in each of those categories, and I think that's by design. I know that we have one category with 5 individuals, and if we shift those names around to one category and then leave another one with ultimately potentially just 1, do we capture the objective of what Elizabeth and Richard did? So I would still propose that we consider leaving a little bit more of this open-ended rather than approve the names unless there's something I'm missing. Sandra?
Can I make perhaps another
please
here? If we approve the organized labor as they were presented and add a position in that category for a broader category of labor, it does skew the structure a bit. But I think to Ian's point, organized labor has a lot to stake in these deliberations. And although that balances a little bit, it would get us out of this conundrum, hopefully. If Ian would concur with that, that'd be one approach. We could approve these three in organized labor, look for a fourth, and hold open the category of healthcare workers for direct healthcare workers with a particular focus on behavioral health. So that's just another suggestion.
Rick.
Yeah, I mean, I think that the suggestion makes sense. I think if there were a real aversion to expanding the size, another possibility would be at an organized labor
Apologies, I couldn't hear
representative.
at all.
Sorry, Richard. Sandra's suggestion makes sense to me. Another possibility, if we're really trying to stay closer to the 26, would be to take Ian's suggestion of moving, or partial Ian's suggestion of moving one of the organized labor representatives into the healthcare workers slot, leaving two of the healthcare workers slots open for further consideration, and then leaving one of the organized labor slots open for further consideration on the thought that we should have a representative of organized labor who's not representing workers in organized labor, but the broader labor community. So leaving, leaving at 26, leaving two slots open in the healthcare workers segment and one slot open in organized labor, and moving one of the organized labor names over into the healthcare workers slot. Ian, I don't know if that makes any sense to you or not.
Yeah. Okay, Ian.
I mean, I guess I respond better to Sandra's recommendation here. I'm averse to saying whether it's SEIU or CNA that better fits in the healthcare workers category. I'm not going to do that. I think at the end of the day, we're trying to strike a balance, and so if I understand it right, Sandra, you're suggesting ask the subcommittee to find somebody else to place under what's called organized labor here, and then let's hold open the 3 slots that are placed under healthcare workers and ask the committee to try, with staff obviously, to try and fill that with the minds to these different categories of frontline workers. Is that your suggestion?
That was my suggestion with regard to organized labor. I think with regard to healthcare workers, the RN here seems to me to be what was intended, and so leaving 2 additional slots open in that space would be fine.
Oops. So to try to do this again and see if it lands, approve the proposed advisory committee membership totaling, if I see it right, we would leave three open, so 22 appointments out of this list of 25. And then for the second bullet would stay the same. And the third bullet would be, again, whether it's the subcommittee or some other process. I do think we have to decide that. And Elizabeth and Richard, I want your opinion on that. But that we would fill any remaining slots in the frontline healthcare worker category.
Just clarification.
Yeah.
So does that suggest we would not revisit the academics or other purchasers? You're just saying you're limiting it to that category?
I am open to having that as an option to revisit, just trying to land, frankly, this piece about how do we handle these 2 buckets here. We can consider whether we want to open the conversation to the other category that, Don, I'm going to broadly call it that you suggested.
And one thought is maybe we strike the the number 25. Was it an arbitrary number? Which would give us some flexibility if we wanted to make a subsequent change, knowing that the spirit of the number is to keep the group as small as possible and functional.
Yeah, certainly. I think in the first bullet, I'm just suggesting we enumerate the number of people we are advancing, right? Not regardless today, and then open to the need to identify some additional individuals who fulfill the need at least around frontline healthcare worker. There's a suggestion of an additional organized labor representative as well. So again, not anchoring to a 25, at least in the motion I'm putting forward. It'd be 23 that we're approving? Okay.
I think that's right.
Okay. I trust that math.
Sorry, it would be 23 that you would be moving to a point as if I'm tracking the conversation, and then the total rather than our rough. And obviously we're not tied to 26 in perpetuity, but we would basically be saying, let's shoot for 27, adding one position to organized labor. And we would hold the 3 open for healthcare workers.
Yes, hold the 3 open. That's
Hold the 3 open. Yes. But it's still,
Oh, yeah.
sorry, I want to make sure this,
Yeah, that was just a comment about leaving all the healthcare worker categories off for today.
yes, for today, that is, the 23 would be moving everyone forward and approving them except for anyone in the frontline healthcare worker category. And then we can determine if there's this shuffle between categories as we consider who would essentially whose names would go into that other category. Okay. Yes, Sandra.
I can ask something not
Please.
related to that at all. So
That would be refreshing.
in the draft motion from the subcommittee, it is not codified about individuals being able to serve unlimited numbers of terms. But it was in the
Presentation.
presentation. So I don't know if we're doing that or not. I was wanting to hear the rationale for unlimited terms. That from a typical governance structure always seems like a bit of a red light for me. So I'm just, if there's a rationale for that, I would just appreciate hearing it.
I can share mine. We really just wanted to leave that to the discretion of the board. I served in a legislature with term limits, and it didn't always achieve what it intended. So again, it was not assumed everyone would continue, but that there would be that discretion.
It's not currently part of the motion, so it does leave it open to even the.
I wanted to clarify that it's open.
Great. Yes, it is. I do think we may not need to stipulate in the motion, but I do want to just ask Elizabeth and Richard how, since there will be a next phase of this, identifying those additional, if this motion goes forward, this category of frontline healthcare workers, is that something that as our current subcommittee you would continue and consider completing if the board wishes that? I ask that with knowing that that's a hard question maybe to answer, but.
Nominate Ian to join. Only because he nominated me. But I think it's really important if we can approve even this majority of folks to get the work underway. I'm certainly open to revisiting this category. I guess I would ask the board to clarify if it might be broader than just this category, because there have been questions about retirees or whatever. So that's the only clarification, but otherwise I'm supportive.
Okay.
So in recognition of the extensive and complex effort of the subcommittee, I guess I'll move the motion as I understand it.
Richard, I see your hand up. Sorry to not see it before.
All right. Thank you. So I too, I'm certainly willing to continue the work of the subcommittee to complete the work on the advisory committee, and appreciate the discussion. I think it's always helpful for the subcommittee to have direction from all of you, because it is the board that makes the final decision. So the guidance you give us is helpful, so that as we do our own deliberations to try to get you recommendations that make sense to everyone. So I think that I'm certainly in support of moving all the names except the two in the healthcare worker space. And sorry, because I'm remote, I just want to be sure I got this correct. I understand that the direction that from the direction of the board is that we would also identify another organized labor person, and also probably reevaluate the healthcare worker space with people who are actual frontline workers. I understand there's some concern that people aren't too much on the management side of things, right? And I think that is actually our intention. So if since we didn't quite meet those, that we should revisit that and do a more targeted solicitation for that. So that's my understanding of what we're being asked to do.
Yes, that is my understanding of what and I'm looking around to make sure we're not missing any. We have head nods. So would it be, David, I know you've moved this for us. Thank you. Would it be helpful, a second? Okay. We are going to take public comment, but I want to make sure that there's no lack of clarity before.
Mr. Chair, one thing
Yes.
to clarify. Will there be an additional member to the subcommittee or no?
As much as I think Elizabeth would like Ian to join, I think we're pretty clear we are capped at 2. So I took that as a comment in spirit.
I'll
But
find another opportunity.
yes, okay. You'll all get on a subcommittee eventually, but no, thanks. Okay. Public comment.
And those who are interested in virtual comment, please be reminded to raise your virtual hand or press *5 on your phone.
Before you go, Beth, lest anyone think we had it all figured out before we walked in the room, clearly we had a bit of robust conversation. So there you go.
Beth Capel, starting off today on behalf of the Teamsters and Unite Here, who I've represented for the last dozen years on the issue of healthcare costs, and have spent the last 5 or 6 years sitting in rooms within the labor movement where we discussed the predecessor to what became the Office of Healthcare Affordability and the work that led to the Office of Healthcare Affordability from the perspective of the labor movement. You all have before you a letter from the State Federation of Labor, my 2 unions, and others expressing concerns. I appreciate the robust and collaborative discussion that the board has had. And would simply add a few points to that. First, Dr. Pisano, as Rick Kronick said, is clearly management. I would say Ms. Wabru is a nurse educator who is administering the onboarding of a BSN program to the nursing school operated by the LA County Department of Health Services. So from the information we have, both of these entities, Altamed and the LA County Department of Health Services, are subject to the targets. When we think about balance, we think about the balance between those who, as Ian said, are negotiating on behalf of workers, those who pay for premiums, whether that's consumers or purchasers, and the balance with those to whom the target applies. And that's how we think about balance. And so there has been a little bit of discussion about that, but we think about it quite differently than what the staff verbal presentation included. We appreciate where the discussion has landed and would look forward to further discussion. My understanding of Bagley-Keene is you could have a committee of
10
3, and that might be worthy of consideration given the complications you've encountered today. I will also note that none of us, aside from you, the board and the staff, have seen the application. So we're unaware of who applied, except when someone tells us. Changing clients and starting my time over as a result. I'm also here on behalf of Health Access. Sorry, I don't do it very often.
You have to get in the back of the line.
No, I don't actually. I could, but do you want me batting cleanup here too?
No.
For which I am notorious at the Covered California board meetings. With Health Access defers to our labor colleagues on who counts as a worker. I would say the matter of balance is one that's important to us as well. And that distinction between those to whom the targets apply, even if indirectly, versus those who pay the bill is important to us. So thank you.
Alternating now to the virtual public comment, Scott Littlehill, you are unmuted. Go ahead. And Scott, you're unmuted on our end. You have to unmute on your end also. All right, we will move back to comment in the room and try and solve that issue.
Good afternoon now. Cesar Lara with the Monterey Bay Central Labor Council. And I want to give you some perspective as somebody that represents 80 unions and 37,000 union members in a part of California. Not all labor is the same. You know, having been with unions for a lot of my adult life, the issues that frontline healthcare unions and workers face is very different than maybe a truck driver or a teacher faces or a hotel worker faces. So having the perspective, and what this committee is doing is trying to make sure that we don't have unintended consequences. And having the voice of frontline workers with the flexibility to have an open voice through a union is important. And so having two of those union people currently into the category of frontline workers, I think is important. Because as I was 24 hours ago at Hazel Hawkins in San Benito County, when the hospital voted to go through Chapter 9 bankruptcy, it is very different than I, as a Teamster, sitting in a health trust trying to negotiate my health care for my members. And so as we look at that, we want to make sure that we do that. And secondly, consider now 40 seconds, is behavioral health. I think that it's important to have the perspective of a behavioral health bureau director or somebody in that realm. And I know Dr. Galley could twist some arms and figure out somebody in California that could do that. And also a nonprofit perspective of mental health and healthcare professionals. I think it's important to the Senator Pan's comment about not growing it, but we want to make sure that we measure twice and cut once. And so thank you for that, and thank you for the opportunity. But I think it's really important. And to go into overtime, like my colleague, social determinants of health should be grounded in everybody on the committee, and that should be a person that is the equity person or the social determinants of health person. It needs to be embedded from day one on what lens the committee is going to do that work in. So thank you.
Back to virtual public comment. Scott, we invite you to raise your hand again if you would like to speak. Moving to Carmen Comsty, you are unmuted. Go ahead.
Good afternoon, everyone. Carmen Comsty with the California Nurses Association. I appreciate the very thoughtful discussion that the board had on filling the advisory committee seats. I just want to re-emphasize that, and CNA agrees with the initial concerns raised by Board Member Lewis about who would be placed into or considered a healthcare worker. Specifically, I think as the discussion bore out today, that healthcare administrators and healthcare management shouldn't be considered frontline healthcare workers, and importantly, their interests directly represent management and wouldn't necessarily represent the interests of workers who are providing direct patient care. I think it's really important as our labor colleagues had mentioned also that there is a diversity in the labor representatives who are on the advisory committee, so that, you know, those who have larger Taft-Hartley funds, who negotiate the plans, have representation on the advisory committee. And I would also just emphasize that one of the nominees currently for the healthcare worker position is actually a nurse educator, which is very different than a frontline healthcare worker, you know, and would probably be more appropriately categorized as an academic, you know, and represents a very specific type of academic perspective in terms of healthcare workers and healthcare workforce. So thank you again for the thoughtful discussion.
Member of the public in the room here.
Good afternoon, Joan Allen with SEIU United Healthcare Workers. Wanted to begin by thanking the subcommittee and the entire board for the robust process throughout all of this. Honored to be a nominee and would be honored to serve if my nomination moves forward. Do want to echo Beth's comments about appreciating a balance between entities subject to the targets and entities not subject to the targets. And so really do appreciate the holding open of those healthcare worker positions, so that those would be more aligned with labor purchasers and consumers, then they would be aligned with the entities subject to the targets. So appreciate that. Do look forward to that continued conversation as to whether the representative from CNA and I which bucket we belong in. But understand that can all happen in the future, but appreciate you moving forward with labor nominations today and also recognizing an additional labor seat. Really appreciate that. Thank you.
Moving back to virtual, Bianca Blomquist, you are unmuted. Go ahead.
Hi there. Thank you, Bianca Blomquist. I'm the policy director for Small Business Majority. Calling in today, speaking on behalf of the 4.1 million small business owners in California. As folks may know, we've been advocating for affordable and quality access to healthcare for California's small employers since 2005. Thank you to the board for your leadership. Definitely appreciate the care and consideration you've all taken to ensure that the advisory committee reflects the diverse perspectives of our state. Picking up the conversation as it relates to the need of the committee's current representation to include those diverse perspectives, we would like to hear from the board where the board anticipates gathering the small business perspective reflected on the committee, and requests that the board holds a space on the committee for Small Business Majority to ensure the diverse perspectives of the 4.1 million small business owners in the state are reflected by adding a slot under the purchaser category. Would also like to add that Small Business Majority has been a staunch advocate of the Office of Healthcare Affordability. We work closely with many of the groups identified on the slide in both a policy lens as well as a programmatic lens, particularly serving as a direct resource to small business owners regarding their requirements and responsibilities as it relates to healthcare coverage. And we're a critical resource to small employers, small business employees, as well as the self-employed who are interested in learning about their health coverage options. So yeah, we believe that the small voices on the advisory committee will be a critical component for the work needed to address rising costs in the healthcare industry.
10
and
seconds.
Understand that this impacts virtually every aspect of the small business ecosystem. So we would appreciate your consideration of our request. Thank you so much.
Moving to additional public comment virtually, Kristen Reese, you're unmuted. Please go ahead.
Good afternoon. I'm Kristen Reese from Southern Humboldt Community Healthcare District, or SoHum Health, in Garberville, California. As I was looking at the nominees, I didn't see representation of a lot of rural and or frontier areas of the state. While it doesn't make up much of the population, it makes up a lot of the area. Our healthcare district covers almost 800 square miles, and we take care of a lot of space in California, right? And there are a lot of different access issues that you'll find in a rural area than you will in an urban area. I just think it's important to have representation from those rural and frontier areas. I'm not intimately acquainted with this proposed membership, but I'm just putting my voice out there, asking that you consider the rural and frontier areas and get some representation there. I'm glad to see that there is another, that there's a hospital district that is important as well.
Noting no additional public comment virtually at this time or in the room.
Okay, thank you to the public for the helpful comments. So with that, unless there's any additional consideration from the board, I'd move to a vote on what is the proposed motion.
All right. Chair Galley.
Aye.
David Carlisle.
Aye.
Sandra Hernandez.
Aye.
Richard Cronick.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell. Richard Pan.
Aye.
Great. And just again, thank you to Richard and Elizabeth for getting us this far and helping us get to the finish line soon. Thank you. Yeah, yes, you get. Oh, Elizabeth said she gets to do it again, only in part, But thank you, really. We are appreciative of your work on this, and to you too, CJ. I know there's an additional component that we want to get.
Not done yet, unless we.
No, let's keep going.
All right. I think we can probably dispatch with this one a little bit more quickly, maybe. So unless all of you want to go to the next advisory committee meeting. So we, as noted earlier, we need to have at least one, likely not more than two members of this board attend each advisory committee meeting. The two options that we considered was that one or two board members would attend all advisory committee meetings, say for a 1-year period. The sort of pros of that is there's predictability and consistency, but there's obviously quite a bit of burden on one or two members to attend those advisory committee meetings that are slated for quarterly and potentially more frequently than that. And then the other option would be that board member attendance at each advisory committee will be determined by the board at a meeting prior to said advisory committee meeting. Staff would solicit interest and availability. I believe that we have one person who actually indicated their availability for the June advisory committee meeting. So in that case, if that's the direction that we want to go, we would continue. We would just decide in these board meetings, likely on the consent calendar, who would attend future advisory committee meetings. I don't know if there's more discussion or what you want to have about that.
Turn to the board for any discussion and questions. Go ahead, Ian.
I was thinking of joking and asking to appoint. I would move that motion.
I'll second it, Mark.
Great. So just to be clear, the motion is the option 2 recommendation. Okay. All right. I think again, we open it up to public comment.
Oh, hold on.
Richard Pan.
Yeah. So.
Sorry, Richard, missed your hand. Go ahead.
So one of the things, because there's a requirement, there's a board member at each advisory committee, is that it's going to be important that we don't wait till the actual board meeting and everyone looks at each other and everyone says, hey, I can't make it or whatever. So I hope that the process is that, the chair through the staff will survey the board members before the board meeting to find out who's willing to attend or whatever. And if it's turning out like there's no one volunteering, there's a little work to do before we get to the board meeting so that we're not, at the board meeting, realizing we don't have somebody and the advisory committee can't meet. So I just wanted to bring that up to be sure that, people need to recognize there has to be a board member there.
Absolutely. We will pre-plan and find out which board members are available for each advisory committee meeting.
And likely have to tell someone who's eager to go that they can't go this time around and maybe the next meeting. So we will work through.
Not the chair.
Yeah, it's, I don't think that's in the statute, but I've got to reread it again.
And then I would
Okay,
just note, I believe for the June advisory committee, I believe Ian has indicated that he's available, but you can correct me if I'm wrong on that. I just got a thumbs up.
I responded to a calendar solicitation. I can't remember right now if that was the meeting that I couldn't do, but I was available for
Okay.
the other two.
That went out from Megan, I think.
yeah. Okay, but Richard Pan, thank you for the clarification. I think it's important. Okay, public comment.
Seeing none in the room, moving to virtual. Seeing no hands raised at this time.
Okay, let's go for the vote.
Chair Galley,
Aye.
David Carlisle,
Aye.
Sandra Hernandez.
Aye.
Richard Kronik,
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell,
Aye.
Richard Pan.
Aye.
CJ, you were right. It didn't take nearly as much time. Good. So I think we are now going to adjourn for lunch and then be back. It's now 12:40. I think give people 30 minutes and then we'll reconvene at 1:10 and see what we can do to keep us on time. But thank you and see you here in 30 minutes. Okay, scene is Dr. Richard Pan. Is he back? Yes. Yes,
Yes.
okay. Richard, thanks for your patience with us. If we could reestablish quorum and then jump into the rest of the agenda.
All right, Chair Galley,
Present?
David Carlisle,
Present.
Sandra Hernandez,
Present.
Richard Kronik,
Here.
Ian Lewis,
Present.
Elizabeth Mitchell,
Present.
Richard Pan.
Present.
Thank you.
Great, thanks. So the remainder of our conversation today is just that. It's conversation. There are no more action items, but they're frankly a hefty set of connected presentations on a number of areas connected to the total healthcare expenditure conversation we had last month. So with that, I think I'm turning it over to you, Vishal, to tee us up, and then you and Michael kicking us or taking us through the slides that we have in our deck.
Thank you, Chair Galley. Today, Michael Balin and I will be co-presenting on the agenda item for total healthcare expenditures measurement. Michael will present background content and experience from other states. I will cover OCA's intended approach for the topic area and prompt the board for any questions. Michael, please take it away.
Thanks. Good afternoon, everyone. Nice to be in the room with you again. So during our second meeting, I just want to recap. You heard from Massachusetts and Oregon about their experience with their healthcare spending targets. We had a review of different ways of defining, measuring, and reporting on total healthcare expenditures. And we talked about potential sources of coverage and spending for total healthcare expenditures. So we're going to continue on the total healthcare expenditure journey today. And we're going to talk specifically about reporting baseline spending for total healthcare expenditures. We're going to talk specifically about payer and provider level reporting, which is a little more complicated. And then we're going to talk about a broad array of different types of adjustments, a universe of adjustments. And as I do so, I'm going to try to avoid confusing you because there are a lot of them. And your statute identifies more than any other state's statute. So I'll try to give a little clarity about the plethora of adjustment options when we get to that part of the agenda. Oops, I went too far. Okay, so the enabling statute directs OCA to prepare a baseline healthcare spending report, and that will be a 2024 activity. It specifically says that the report shall include total healthcare expenditures, so that'll be spending is X billion dollars, for example, that's what we mean by total, and also per capita expenditures, so spending per person per year. And then as appropriate, okay, so there's some discretion here, disaggregated spending by categories such as, so this is not limiting, but such as service categories, consumer out-of-pocket spending, healthcare sector, which is a term that needs to be defined by this body in the future, and geographic region. So I'm going to walk through some of the options for measuring and reporting total healthcare expenditures. I'm going to start by talking about the different levels, and this is something that I presented previously to you, and Vishal made reference to it earlier today. So in other states, the common, if actually universal practice, I should say, is to report at 4 levels. The state level is really a roll-up of the markets plus other smaller payers. So, for example, 5 states this spring reported publicly on their total healthcare expenditure per capita growth from 2020 to 2021. Okay, happened just the last few months. Just as a matter of interest, the range was 3.2% to 11.2%. A lot of variation. Okay. They also reported by market. And by market, I mean commercial, Medicare, and Medicaid, commercial inclusive of fully and self-insured, Medicaid inclusive of managed care and non-managed care or fee-for-service spending, really not anything that doesn't flow through the health plans, and Medicare being traditional Medicare or Medicare fee-for-service plus Medicare Advantage. The special focus when states report on this is always the commercial market because that's where spending is the highest. And when states report at the market level, they will report on both total healthcare expenditures and then separately on total medical expense. So they do both. And the reason for that is insurer admin and profit is highly volatile. So for example, commercial insurers made big margins in 2020 because people didn't utilize services. Those margins shrank a lot in 2021. So net cost of private health insurance dropped dramatically. So because of that volatility, oftentimes states will report both the total healthcare expenditures for the commercial market and total medical expense. As a point of interest, total medical expense across the 5 states, now I gave you THCE, which is all markets, all spending, was 3.2 to 11.2. Total medical expenditures in the commercial market in 2021 was 9.7 to 18.8. Okay, that's a big range in terms of variation. Now, the numbers were particularly high in 2021 because spending was depressed in 2020. So that has to be in context. And in a number of states, they looked at what was the average annual trend from 2019 to 2021 because of the dip in spending that happened in 2020. Then there's reporting by payer. So that's individual payer by market. It does not include the smaller payer categories that we talked about last time. So states are not reporting on trend for the Veterans Health Administration or State Department of Corrections health spending. They're really just reporting on Medicare, Medicaid, and commercial payers. And again, by market. So if a payer happens to be in 3 markets, then it gets reported 3 times. And then finally, the provider entities. The provider entities are only reported for total medical expense because insurer admin and profit doesn't apply to them. Okay. So any questions on this? I know we've covered some of this before.
Could I just clarify that last comment you said? Do they, for payers, total admin and profit aren't included, but are they included in TME for provider entities in these other states?
So provider spending doesn't include the payer admin. The payer admin is included in payer reporting, but not in provider reporting.
But it includes their administrative expenses and their profit margins?
For the payers?
For the providers?
So what's reported for providers are payments to providers for their attributed population. Okay, so the whole focus is not on provider costs, it's on provider payments. Okay, which is important to sort of get your head around. It's not what are the costs incurred by providers. It's never about that. It's what are payers sending to them for their attributed patient population.
So,
Yeah,
this is
go ahead.
Ian. Yeah, so I mean, sort of along the lines of what Ian asked about is that and we've been seeing a shift of essentially administrative burden and costs from payers to providers. And I think we mentioned this a little last meeting as well. Should there be some effort to capture that? Because that's, increased admin costs, basically increased costs overall without actually improving necessarily, improving either access or quality of care, right? Just increased costs. So there should be some effort to capture exactly where the admin costs are happening.
So that could be done, but I would say that's an ancillary activity. It's not measuring spending against a spending target. So I'm not saying it's not important or insightful, but it's a different activity.
Okay, well, I would just argue that if costs are going up, if providers are, quote, spending more because they're having to have greater administrative burdens, that's not the provider's fault. And so they have more overhead and so forth because that is shifting, then penalizing providers for essentially payers saying that we won't pay you unless you accept greater administrative burdens is a problem.
Yeah, I would say understanding why spending is growing is a separate activity from measuring spending, which is really what the spending target is about. So I'm not disagreeing. Again, I'm just saying it's a separate task. Rick?
Part it's a semantic question, but an important one. We're separating total medical expense from total healthcare expense, separating out on the insurer side administration and profit, but there is administration and profit on the provider side as well. And so it's kind of there's this question of if we're separating administration and profit on the insurer side, and we think that we're just measuring medical expense on the provider side, but that's medical expenses also including administration and profit, some of which returns potentially to somebody else because medical groups are, affiliated and kind of part of other things. And so it is important to keep track of it.
Yes. Yeah, I don't disagree. So when we think about levels of reporting, state level measurement, this is going to be the headline on what's happening in healthcare spending in California. And so every year when OCA reports out on performance against a spending target, that headline, at least as it plays in other states, is state performed well, not well relative to spending target. Okay, so this is the roll up and the measure, but boy, there's a lot that's underneath it. And when you report on state level, you can break out by market, you can break it out by admin and profit. There are ways to understand it. You can also understand it by market. The trends by market will be wildly different. Medicare, Medicaid, and commercial will never look the same, and they won't look the same from year to year. So there are some states this past year that looked really well despite the fact the commercial trend was super high because their Medicaid trend was negative and their Medicare trend was barely over zero. So overall, they might say, we did pretty well, but their commercial market was a disaster. So it's why it's really important to break apart the three markets and to evaluate them separately and not just to look at the top line state performance. Measuring at the payer and provider entity levels is important because the underlying logic model for a spending target is that through transparency, there will be enhanced accountability. And so that's why it's important to report by payer and by provider entity and by market, because the market trends are so different. And in the states that have historically had lower trend, the states that have spending target programs that have lower trend, what I have heard anecdotally is that negotiations between insurers and providers start with their spending target in the center of the table. Okay? In states where their trends are really high, that's not happening. So in states, I want to say this is anecdotal. I don't have a scientific study. I want to disclose that. But the states that seem to be doing a little better on trend and that did better on trend in 2021, what I hear anecdotally is when insurers and providers negotiate their contracts, they negotiate around their spending target. Okay? And I've heard anecdotally in some other states where it's way higher that that's not happening. The spending target is discarded. Now, there might be someone who introduces it, but there's not a mutual effort to negotiate from the spending target. Okay, so it's a critical part of the success of your spending target is to have it become the center of conversation. And that's why having clear transparency helps promote accountability. Okay, so this payer and provider entity level of reporting is in my mind really important. Okay, because by naming names and sharing performance data, you create some motivation for people to want to perform well because their performance becomes public. And I can tell you, there's one state that I am working on where this year they reported at the provider entity level for the first time. Provider organizations that were never paying attention to this program all of a sudden had lots of questions about the state's methodology and where did the data come from and what are the calculations you used. It matters. There is reporting in some states of an other category because we've got all these smaller categories of spending that we talked about last time that I just referenced again. Department of Corrections, Veteran Health Administration, Indian Health Service. All together, relative to Medicare, Medicaid, and commercial, they don't amount to a ton of money. So typically when states report out, they aggregate the other. There's no attempt to hold these categories accountable to the target, but for completeness of the picture of spending, they are grouped together and reported that way. Okay, Vishal?
So I'll be going over OCA's approach for levels of reporting. For the baseline report, OCA's preliminary approach is to report at the following levels. For state and market, we would report THCE. For payer, we would report insurer level THCE, which is inclusive of total medical expense and insurer administrative costs and profits. This third bullet, payer other, will be niche programs, niche public programs like VA, TRICARE, Indian Health Services, depending on data availability. And then we would also report at the provider entity, we would report total medical expense. OCA anticipates measuring insurer and provider entity level spending for accountability purposes. By accountability, we mean enforcement for the spending targets. We would do so in a phased manner. 2025 is a performance year only, which is not subject to enforcement. And 2026 the second year of the program, would be an enforceable year. So performance would be subject to the target or subject to enforcement, excuse me. Next slide. Does the board have any questions regarding OCA's contemplated approach for reporting baseline spending at the state, market, payer, and provider entity levels?
Go ahead, Don.
Yeah, so one question. Do you put third-party administrators in with insurers, or are they somewhere else? So for self-insured plans, you have a TPA that is functioning in many ways like an insurer.
So for Michael, if you could weigh in as well.
Sure.
For payer reporting, from the experience of other states, they do require that the carrier or the payer report by lines of business. So it could be, Medicaid, Medicare Advantage, and then for the commercial market, we could ask them to break out the data by commercial, fully insured, and then commercial self-insured.
Yeah, I'm not weighing in on that. I'm just wondering where they are, whether they're in the insured bucket.
They're in the insured bucket.
Okay.
Yeah,
that's what
they're
I
combined
figured.
together.
Okay.
There are no states to date that have standalone TPAs that report, because most of the TPA business is through the plans, the big carriers. There are states that have looked at TPA volume if they have the data. Some states have it, some don't. Those that do have the data have found that the standalone TPAs that are not part of an insurer just don't have enough volume to make it worthwhile. We could look at that for California to see if there are any where their volume is so large that.
Yeah. So I think that probably makes sense. I think you probably capture most of the TPAs by looking at insurers because they function both ways. The sort of one question would be point solutions, which are becoming sort of more part of delivery, and those are not insurers. Those are standalone, like care coordination entities or benefit and management entities. But and I'm assuming those would also be under insurers, but they're decidedly not insurers. Many of them don't bear risk at all.
Yeah.
Some do, some don't.
They're not paying claims. They're providing admin services.
It depends.
Yeah.
Yeah.
So,
but they're increasingly part of care management, and that and they're taking on the role that traditionally would have been delivered by a TPA.
Mm-hmm.
And some of the arrangements are capitated, some are fee for service. It just depends.
Mm-hmm.
But they're a sizable portion of the landscape right now.
Mm-hmm.
Yeah, agreed.
Go ahead, Rick.
I know there are a series of slides coming on geography and the kind of the tale of two states or a tale of many states. But I'm confused and hoping you can clarify on this reporting. It doesn't say geography here. Are you intending to include that and it just doesn't say it? Or, yeah, what's the story about geography?
Yeah, that would be another dimension. Those levels that we showed in a few slides back. Geography would be another cut of the data, another view.
So the OCA's approach for levels of reporting would include then geographic breakdowns, or not?
Yeah, I think once we get to the geography section, it'll be a little more clear. But for statewide THCE, we're talking about covered California region, so that statewide number would be the kind of the one number. But if we talk to the payers about feasibility, about geographic breakdowns, we could do it at a more granular level.
Yeah, I guess, I started with the question. The comment would be, as I think your subsequent slides show very clearly, it would be really important to do this, and really important to push on feasibility, which, as far as I understand, if they can report at the provider entity level, which is clearly key here, you ought to be able to then do this at a geography level. And it would be very important to try to do that.
I saw Richard's hand up, and then we'll come to you.
Yes.
Richard Pan.
So
Great.
thank you. Thank you. A few questions. Sorry, I'm going to lean in so you can hear me better. So first of all, I guess I comment apropos our last discussion. You said providers is total medical expenditure, but again, I think we need to acknowledge there is administrative expense folded into that, right? It's not planned administrative expense. So when you call that all medical, that's not necessarily true. So there is a matter of semantics, but a very important one so that people understand what they're measuring. But I guess the other question I also have is that, so I see is that we have, state, regional, then you have provider, and then you have sort of the plan, and then provider. But I guess my question is what's the definition of provider? And so you're going to do one for each, you're going to have a THC for each plan. And then are you going to have it for each provider? And then the thing is that since some of the providers, quote unquote providers, are actually, risk-bearing organizations that then have other subcontracts, right? So you have plans having contracts, right? So and we've seen this problem actually with Medi-Cal, where we do the oversight at the Medi-Cal plan, and they have some contracts with groups, and then by the time it gets all the way down to the the frontline healthcare workers and professionals, all sorts of stuff have happened, right? But we're missing all the layers in between. So when you say provider there, what do you mean? And also, what happens when you have multiple layers? So you have plans collecting premiums bearing risk, they're then paying capitation to groups or systems that then have another set of contracts, et cetera. And so they're kind of asking, they're intermediaries, but they're actually, they're making those kind of decisions as well, and they're taking their share of the admin costs along, charging that along the way. So they're kind of like plans as well as providers, not really providers. They're kind of like, so they're sort of in between.
I could start off. Yeah, we're fully aware of all the levels of delegation and the complexity and administrative costs at each level. We are, working to understand those delegation arrangements and contracting arrangements that payers have with providers so that we could appropriately measure provider entities, which, in this case, just taking physician organizations as an example, that we do it at an appropriate level, but do kind of recognize, the what you're remarking on about the multiple levels of delegation.
Okay, so I realize you might not be able to answer the question right now, but I would appreciate more information about how you plan to approach that.
Yeah, we certainly hear you. Like Michelle said, we're looking into it. I mean, I anticipate we'll certainly be collecting higher levels of data from the risk-bearing organizations, the larger health systems, large FQHCs and the like. But we are working our way through the details. And I think it's really important, Michael. So you helpfully tell us what other states are doing, and we're California, and we do have this very complex and very extensive sub-delegation that goes on, where you have a big plan and a sub-plan and a capitated medical group. And so we do hear you, and we will look at whether we need to do something differently in terms of admin costs and profits for some of those large RBOs. We may have to tackle that.
Yeah, this is a uniquely California phenomenon, and it's not very opaque, what happens layer below layer below layer. And that's going to limit some of your measurement activities because of the lack of clarity. I think oftentimes you're going to have to measure provider entities at a level knowing that they are passing down risks to who knows how many levels of organizations that you can't see. And you can't see it largely because the payers can't see it. They don't actually even know what all the dollar flows are below the lead organization they're contracting with.
Although I would point out that whether they know or not, they are the ones with the contract. So they don't know. It's perhaps they don't want to know.
Yeah, for what it's worth, in the Medicaid contract that we just put out, the model contract, the attempt is to get through to some of that and require any plan to understand each level of delegation and what's happening to costs and payments. So hopefully that gives us over time some sense, at least in a segment of this, the impact at each level.
Yeah, I will add that if your payers did know all the levels, the complexity of trying to do this measurement and tracking it at all the levels would be mind-boggling. So what you don't have, or if you had what you don't have, it would not make your task any easier. It would make it much more difficult.
Mm-hmm.
But I was going to agree with Dr. Pan's need to get a lot of clarity on the provider level. I agree with Richard also, like we need to push feasibility. I understand that this is hard and other states don't have to do it, but that's the only way we're going to get insights into these drivers. So anyway, I hope we push on the feasibility.
Yeah, and I'll say it's not just the delegation, it's also the delegation is capitation. And it's capitation for which there's not either any or detailed encounter data coming back. So that also creates a lack of clarity in terms of how care is being delivered.
I guess, I mean, this, there's a reference to the encounter data problem later. I am confused about that. I mean, certainly in Medicare Advantage, there's detailed encounter data even with capitation. I mean, in Medi-Cal, others would know better than I what the current status is. You know, it used to be a big problem. Like here, that we've gotten much better. I don't know how much better.
Better and continuing to improve, I would say.
Don, CalPERS, what's the quality of the utilization data that you're getting on members in CalPERS?
Good. I mean, sorry. I was on the whole time apparently. Okay. No, I mean, we see essentially every claim.
Yeah.
We pay them because we're flex funded, so they come through us, and so that's pretty.
I think the University of California benefits folks would say the same thing. So I mean, it's an important question about kind of what is the quality of the encounter data that are available.
Yeah, we're not hearing from the carriers the same thing that Don's saying about we see every claim.
Could I just say, from my own experience of building a multi-employer claims data warehouse, we've been able to shift some payers who are capitated, very large payers who are capitated and subcontract on a capitated basis. They figured it out, and we're getting great encounter data that's comparable to a PPO environment. And there are other payers, my suspicion is with Dr. Pan's, that there are some who simply aren't motivated to find out or pass that information on, and I think we should push them on that.
Yeah, I think just to summarize, because I sense the urge to keep moving on, but I think there's a lot of agreement that just because we can't today or it's complex to do it, once again, I think this board is interested to figure out what it looks like to do it, not to slow progress on moving forward, but to really ask these questions now and really for the team to help us think about how one would push on that. And you heard some examples of where what seemed hard or impossible is actually happening in a number of different places. So we'll keep on that.
Okay, our next topic, Rick, the one you're waiting for. Oh. Sorry. Okay, geography. So I think this is of interest to many of you. You're all aware that there's significant difference in healthcare spending and in prices between Northern and Southern California, and no doubt also other finer differences between urban and rural, and even within Northern and Southern variation. So this is just a little bit of data that shares the extent of that variation. And lots of variation in prices, as you can see here, for discrete services. These are 4 services with just a tremendous amount of difference. And all this plays out into variation in premiums because of the underlying prices and spending is different. So too are going to be the differences in premiums. So understanding differences in spending by geography is relevant, particularly given both the size of the state and the amount of variation in spending. Although I will say there's variation in spending even in small states by geography. One observation here, because I've been referencing what happens in other states do not, through their spending target, measure differences in spending geographically. They tend to use their all-payer claims database to look at differences. I will also say, though, that geographic differences are not, they're not as elevated a policy issue as they are for you in other states. Which doesn't mean that there aren't differences. It's just, it's not a high policy priority topic. So they are known and acknowledged, but I just don't think that they are the focus of as much attention. Shaw?
So for OCA's approach for disaggregating THCE, we would like to collect data from payers in a manner that will enable geographic analysis. This would allow OCA to examine regional variation and inform discussions of the potential consequences of regional spending variation, including on access, equity, and affordability. So we would need to define those geographic regions for the data submission process from payers. Initially, we're considering the Covered California rating regions. We would need to engage payers and solicit feedback from them about the feasibility of collecting data for the purpose of geographic disaggregation. And then we'd also want to ask them about the ability to collect or collect and report data at an even more granular level. So with that, does the board have any questions about OCA's approach?
Or suggestions on what regions to use? I mean, we looked at Covered California and didn't have suggestions of other models, but you all may.
We have a different breakdown. It's for public agencies, it's 3-part. I would go with Covered California's. It's much more granular. You know, the only other thing, just as and I don't know whether this is where you're headed with the sort of opening the door to going more granular, but you're looking at the spending at the prices data. I'm thinking of the Zach Cooper work, and you see tremendous variation within these places, and so it might, you know, I don't know what I mean, how you get that granular, but it does seem it's relevant, certainly. Rick, you're going to say something smarter than just identifying the problem.
No, I was just going to support the idea of using the Covered California regions. I think that's worked well for Covered California. It reflects pretty much the broad geographic diversity issues that we see in variations in costs. So I think that's a very good proxy. I was just going to ask this question about what a more granular level would be or could be.
Yep. So initially, you know, that we've explored, you know, census level, tract, zip code level. You know, zip code is obviously the most granular you could go, but you know, we are kind of recognizing a crawl, walk, run approach. So we want to really understand kind of the feasibility and the challenges with reporting data at various levels.
Rick, go My suggestion, I like the cover California granularity also. I think it works well, with one possible exception, which is Los Angeles County, because of its population, of course. But there's also a structure in Los Angeles that might be amenable to this, which is the service planning area, which is designed for healthcare regions. Each spa probably has close to the population of much of Northern California in it. And there may be significant variation in cost and utilization within those regions.
And I also support the cover California rating regions. I mean, that makes sense to me. And I know I'm sure you're thinking about sort of what things you want to get from payers through this process and what do you want to be getting through the HPD or other processes. And, my reaction, Don, on kind of prices, that assuming that the HPD actually is going to be there and producing stuff, that's, probably a better way to get there. If you wanted to get to the granular levels of census tract, et cetera, again, my kind of gut would be the HPD would be eventually a better way to try to deal with some of that. But at the covered California rating area, I mean, if carriers can produce information at the provider entity level, which they have, is my understanding, in other states, it seems like a sort of baseline requirement to do any of what we're talking about, then I can see some difficulties, but it is hard to see why those difficulties couldn't be surmounted to be able to produce information also at the covered California rating area level. I mean, there are some provider entities which will have patients in more than one rating area, and they'll have to sort of parse that out, but that seems manageable.
I see Richard's hand up.
Yeah, I agree with everyone else that we should use the covered California area. Someone who actually worked on it at the legislature way back when. And I'm not suggesting we do this now or even in the next few years, but I also recognize that those areas were established now more than a decade ago, and populations shift and so forth, and might be something that not, I would say us, but maybe working with Covered California, just to do a cross check about those areas, they still continue as they currently are, makes sense. But that's a bigger thing than what we're talking about now. In terms of the granularity, I mean, I guess it's always more fun to get more granularity, but I do wonder how much how much more information we get if we create more granular geographically. We're going to be looking at lots of different layers, except perhaps for as David said, LA is a whole different beast. And so I certainly understand what he said about Los Angeles and the fact that each of those spas is about as big as, other huge regions. And there might be some benefit to subdividing the LA area into those spas, just given the number of people that are affected. But I would also just say in terms of granularity, there might be other cuts of granularity we might want to do aside from geography that may actually be more informative or more useful from a policy perspective than more geographic granularity.
Yeah, I think before Sandra, you go, just a couple comments. I'll talk to the board chair at Covered California as well about that. But LA 100% agree that it's 2 million, or not quite, but that's supervisorial district, but north of 1 million people in many of the spas. So it does make sense. I like that suggestion, David, to look at it. And just to your point, Richard, I'd be, personally interested in thinking through the granularity on the geographic piece pretty strongly, only because and you'll remember this, Richard, in preparing this legislation and moving forward, that was one of the drivers trying to understand what's happening within even pretty narrow geographic regions with healthcare spend and what the pressures are on specific employers or in specific regions. So I want to make sure we don't lose that if we can figure out the right way to do it. So I appreciate the approach that is being suggested here. Sandra?
I don't remember now, but it used to be that the feds had certain geographic areas that were targeted as being underserved. And as you think about granularity, that might be a lens that would help us get at health equity. And so where those designations are today, I don't know how many there are, but that might be an area that from the perspective of what we're trying to do here on equity would be helpful.
Yeah, absolutely. I mean, and Dr. Carlisle could speak to this. Of course, OSHPD and now HCI have been doing that work for a very long time. So we certainly have that data and we'll look to it as well.
And David lives and breathes in one of those designated areas.
I'll just say, very good point.
Yes, 100%. I agree.
This may not fit here, but are there plans to also collect cost sharing information? Like how is affordability being experienced by the people paying for care? And I know that's hard to get in claims, but is there a way to look at that as well?
Our statute does require that we have THC and cost sharing as one of those categories. Cost sharing is one of the categories for TME. So we would report it at that level.
Just follow up. Vishal, when you say you'd report at that level, so what I'm not sure how far along the planning is, but what would you plan to report?
Report cost sharing?
Yeah.
I'm thinking it would be at the payer level. So Michael Bailett, so when other states report payer data, they report it out by the different buckets of claims, non-claim spending, and consumer out-of-pocket spending?
No, other states do not collect consumer out-of-pocket spending through their target submission. They will measure it through their all-payer claims database by looking essentially at the difference between an allowed amount and a paid amount. And so they're isolating the patient obligation. But that's what other states are doing. They're not including it right now in the submissions that the payers are.
I would agree with Elizabeth, and especially given the statute, that it would be important to try to do this through the information that the payers are submitting. I mean, obviously they won't know what's paid out of pocket, but they'll know what the deductibles and the co-payments are, what was supposed to be paid at least, and trying to get information on that.
Yeah, that's something we're definitely interested in. It's required in the statute, and also for us to be able to track trend in consumer out-of-pocket obligations.
Yeah, and that will get to the total. It won't get to the distribution problem, which maybe for that you need to go to the HPD. The problem of for some people, this will be really unaffordable. And how is that changing over time? And that's probably not something that'd probably be really tough to get through the payer reporting, but it's crucial to be tracking through the HPD.
Yes. Oh, I see where we are. We're too far ahead. Okay, so the next category of disaggregating is by service categories. This is one of the possible options listed in the statute. Other states all do this. Their categories aren't exactly the same, but they're pretty similar. When payer data allow it, this comes back to the capitation issue. Sometimes payer data will not allow us to disaggregate by service category because all the payer says is we paid a capitation. We have no idea what happened afterwards. So when payer data allows it, it would be possible and consistent with other states to report by the service categories that you see here. They are broad. They do not provide the detailed drill down that you would get out of an analysis of claim level data, but they certainly will tell you which categories of services year over year are driving spending. And I'm going to give you an example from another state shortly. But I want to note that where there is capitation and the payer doesn't know what services are actually being delivered, we will not be able to categorize spending by service category. So it won't be 100%. And that will differ by payer and by market. So next, I'm going to give you an example of an analysis. This is 2021 spending data at the state level in Rhode Island. This looks at what were the cost drivers per year. The size of the bubbles indicates the total spend in the category and the growth. So the bubble size tells you the relative impact on trend for that year. So looking at this, we know that hospital outpatient, the biggest bubble, was the primary driver of spending. We don't know from the data that are submitted whether it was price or utilization, but Rhode Island separately has some sophisticated dashboards that sit on top of their all-payer claims database that reveal that for 2021, it was utilization. And that's because utilization was depressed in 2020. I will say that historically across other states, almost every year, the cost driver is price, not utilization, but that was not the case in 2021 because of the depressed utilization in 2020.
And given the fact that it's the second biggest bubble in Rhode Island, what is under other professional?
So in Rhode Island, you have a lot of non-physician behavioral health in that bubble. And the last few years in Rhode Island, their outpatient behavioral health trend looks like this. We don't know that from their spending target data, but we do know it from their all-payer claims database data because they're able to look at utilization and price and total PMPM spend for outpatient behavioral health. They can do it by market, they can do it by gender, they can do it by age band. And so we've been able to graph and see that other professional is a huge amount of growth in outpatient behavioral health. And in this category, it's non-physician behavioral.
Michael, before we go on, I saw Richard's hand up just now. Richard, jump in, and then we have a few other questions around the table.
Yeah, so a couple of questions. One is that hospital outpatient covers what? Does that include physicians who work in an outpatient, or is it only facilities fees? It's not the
just facility.
Fee? Okay, so that's just a facility fee part then, right? So if
yeah.
there is,
yeah.
Okay. All right, so that's interesting because, all right. And then actually, can you back up a slide? Sorry, there was a question I had that, yeah, so, all right. Yeah, so I guess the, sorry, okay, yeah. So I mean, I guess the definition of primary care, that does not include. So just want to be clear that is not subspecialties of primary care specialties, right? So in others, if for pediatrics, that would not be pediatric subspecialists, right? That's just because sometimes they say, oh, primary care is pediatrics, internal medicine, and family physicians, but then they also include the subspecialty stuff in there as well. It's like, no, those are subspecialists of our. So just
yeah, I mean, I'll say these definitions are up to you. I'm just sharing this. These are categories that other states use. States that measure primary care, because they often have primary care spend targets, they tend to have much more prescriptive definitions of primary care is down to the code level and the service provider level. The other categories, they're much more broadly defined, and the payer has some discretion in terms of how they categorize it. I will say so also some states that have behavioral health spend targets also have very prescriptive specifications just for that category. Not every state has it, but this is just a generic example.
Okay, well, I'd be interested in seeing what we're planning to use for primary care to be sure we're actually capturing primary care. And I would actually say that we might want to have a specific one for behavioral health. So instead of lumping it into other. Thank you.
Yeah, so Article 6 of your statute has a whole separate provision about measuring primary care and behavioral health. So one thing we'll need to figure out is how to reconcile that piece of the statute with this piece of the statute.
On the price versus utilization issue, so as one of the people who has always said focus on price, not utilization, that's where the problem lies. We are seeing continued weird utilization patterns, not just the difference between 2020 and 2021, but ongoing, and some of them seem to be stickier, as in like may stick around long after we've seen the post-COVID bubble not be a bubble. So I do think it's just worth paying attention to that in a way I think we needed to pay attention to it less in the past.
John, what do you mean, John, by weird?
Less predictable. So we've seen, as Michael pointed out, really dramatic decrease in utilization in 2020, followed by huge increase in utilization in 2021, not just comparatively, but just period. And then there's some sort of bubble where people are getting care that they weren't getting during COVID that has continued to cause high utilization patterns. Some of that is just a matter of working it through the system. Some of it continues to just be higher utilization and different utilization patterns. So the classic example is behavioral health. So there's just a lot more people seeking behavioral health services than there used to be, but it's not just behavioral health. So in professional services, we're seeing some of the same things, and we just don't know at this point what's around for a long time and what's temporary and so forth. And it confuses like predictions and everything else.
We don't know what's normative, quote, post-COVID utilization levels.
Is it going up and down, or is it just staying higher
Some of it is coming down, and some of it is staying higher longer than we would have anticipated. And some of it just seems to be the case that people are seeking services that they didn't seek before. And folks who are getting treatment for behavioral health conditions that may have existed long before COVID or may have come about and be lingering because of COVID, they're getting behavioral health services at a much higher clip in our data. And some of the professional services we're seeing, it's not as pronounced as behavioral health. Behavioral health is the most pronounced, but we're seeing some of the same kinds of trends.
What we've seen, Don, I'm not sure if you see this, but we see the outpatient behavioral health trend is actually far predating COVID. But when COVID hit, then it did a big jump up, but there was already a multi-year trajectory that was upward.
So
It hopped up. Yeah. Right.
I mean, one thing, to state the obvious, the quote pent-up demand was a lot of maintenance support that people lost, and therefore cardiac conditions that were well maintained are no longer. And so the level of need, you didn't just delay care and need the same thing you needed 6 months ago. You need something quite different. I wonder if that's what's keeping it up.
So anyhow, I shared this example just so you get a sense of what's possible if you have payers report the service category level. This is state level, but you and states do report this by market as well. And it allows you to see visually that what's the cost driver for Medicare isn't for Medicaid and isn't for commercial. The big difference when you look at these by service category is long-term care is an enormous bubble for Medicaid. It's not for commercial or Medicare.
Will we get to the point where you can see which hospital, which outpatient facility? I mean, is that drill down planned?
So the spending data that comes in isn't at that level. It's aggregate. So Yeah, I know we've talked in the past about having to have this parallel set of analytics that sits on top of the HPD. And so there's another state in which I'm working where they have by hospital, by service category, 5 years of trend on utilization, payment per unit, adjusted for outliers, adjusted for COVID vaccines and tests, so that they can tell a story and pull out, which hospitals, for example, have much higher payment levels, much higher trend, how does it vary by service? So all of that is possible, but it's probably not going to come through your spending target program because the payers are submitting aggregate data, not claim level data. That's what the HPD can provide you in parallel. And I would say needs to provide you in parallel, because this just isn't detailed enough to do the type of analysis that you want. But if you have that available to complement this analysis, you can look at this and say, hey, we really need to drill down into other professional what's going on. And you turn to your online dashboard that's loaded with 5 years of claim data, and you can figure it out right away. Okay, easier said than done, but it's doable, and there are other states that have done it. So this isn't a theoretical. Okay.
We like that at least one of the ideas around the table is easier said than done.
Could I just, I like generally where this going, and given the data limitations, this plus behavioral health seem the right set of categories. My recollection, and others in the room might be more acquainted with it, is that rate submittals to the state follow roughly the same categorization, or the rate build-ups. And as we hone what these categories are, it would be, I don't think we should be handcuffed to those definitions, but it'd be nice to put side by side what the spending increases are compared to what the large and individual and small group markets are tracking on premiums.
Yeah, I think something, Vishal, we could do with DMHC. Yeah.
Yeah, we are coordinating with our sibling departments to look at how they could support our efforts on measuring performance against a spending target, and also how it relates to the affordability set in terms of changes in premiums. So with regard to OCA's approach, we're already planning to disaggregate THC by service category. I did hear some comments about primary care and behavioral health, and kind of how does that fit into some of those categories. So we are doing some information gathering through separate work groups to better define kind of the discrete service codes and all of that. And that would, have to be a more granular reporting than those categories listed. So next month, you'll receive an overview of our planning efforts related to primary care and behavioral health to kind of see how that fits in the timeline. Do want to note that there is a distinction between the baseline report, which covers calendar years 2022 and 2023, and the data submission kind of regulations that we need to finish by the end of the year, that we may have a more kind of simpler or higher level reporting for that report. But then once that separate work group develops more recommendations, or OCA gets more information from that work group and stakeholder input, we could have future cycles of reporting have more granular reporting for those categories.
Have you guys thought about how Kaiser will collect and report data? Have other states dealt with Kaiser as a fully integrated delivery system?
Yeah, we're actively engaging Kaiser in kind of these technical work groups, so we could, because they are unique as both a payer and a provider. So we're working with them on how to report the data appropriately.
Kaiser currently reports in both Washington and Oregon.
Keep going, please.
Okay, so the statute says that the office shall create requirements for payers and fully integrated delivery systems, that's Kaiser, to submit data necessary to do three things. I am going to focus here on number 3, identifying the annual change in healthcare costs of healthcare entities, and specifically provider entities. I think all of you will have a grasp of this issue, but I want to note that in order to measure total medical expense by provider entity, we have to attach patients to the provider entity. And for capitated arrangements where there's a primary care physician identified, then we link the member or the patient with the primary care physician, and then the primary care physician with the larger provider entity. Where there is no capitation, we have to have patient attribution rules where we look at utilization patterns for the patient and thereby attach the patient to a primary care provider to a larger provider entity. And that's principally going to be with EPO commercial products. But also people who for some reason are not are floating and not part of some program where they've got an identified primary care provider.
Michael, in other states that have worked on this, do they prescribe the attribution rules and give them to the payers and say, thou shalt use these rules, or do they leave discretion to payers about, tell us how you're going to attribute patients?
The latter. Oh, my mic's gone out? All right, sure. I think, Rick, in other states, they've concluded that trying to get all of the payers to switch their attribution methodologies is more than they want to take on. Mm-hmm. So universally, they tell the payers to attribute using whatever their current attribution mechanisms are.
And do they at least get information about what those attribution mechanisms are so that they can compare them and understand?
They have tended not to do so. Mm-hmm. That certainly is possible, but that just hasn't been an area of priority. And I will say there hasn't been a lot of noise about that either from any front. Nobody has seemed to be concerned about relying on the existing attribution methods that the payers are using. Okay, you certainly could do otherwise, yeah, but I'm just describing what the practice has been in the other states.
Thank you.
So just to make this clear, I think you all get it. Being attributed to a clinician does not mean that the member is required to see the clinician or that the clinician delivered all of the care that the patient received. But this attribution, whether it's through member choice in a health plan of a primary care provider or through this claims-based attribution approach, is critical to linking spending to members and members to primary care providers and primary care providers to larger provider entities. And this is a universal practice across all of the other healthcare spending target states.
Do they all do this on a direct member one-to-one PCP basis, or do some do it on an episodic basis? Episode of care?
No, I don't think any of them do it on an episode of care.
Thanks.
Now, one other thing. Medicare fee-for-service does not do this. It is possible to get Medicare to share healthcare spending for Medicare fee-for-service with a pretty simple request. They'll provide the spending by service category, but there are other things that they won't do. And one thing they will not do is this level of attribution.
I would expect part of the reason they don't do that is that it's wildly inaccurate. I mean, it's in a PPO environment, as in traditional Medicare, you have folks who don't even see PCPs. I mean, they use a specialist as a PCP, or
Right.
they just shop for services that they feel like they need, and relating them back to a particular PCP seems highly arbitrary.
Well, in that case, they wouldn't be done. So it is common that the percentage of a commercial PPO population that's not attributed is pretty high. So you will not get 100% of the population attributed to provider entities.
So there's a pattern that needs to be established in order to do before you get to attribution. Is that what you're saying?
Well, so there are a set of attribution rules. So payers will look for, the number of visits that somebody's had with a PCP in the last year or 18 months. But if someone has had no primary care utilization in the look back period, and they've only been seeing specialists or going EDs or had no utilization, they don't get attributed.
So that's certainly better, but also flawed, because I mean, you're gonna have people who go to their PCP for the 9 things that they see a PCP for, or they envision you see a PCP for, and then go see specialists who are not referred by the PCP. They just go see them because they can, because they're in a broad network.
Yeah. Oh, it's definitely imperfect. I mean, if they happen to go to people who are part of the same system as the PCP, then the attribution to that system is still okay. But if they're going to one provider entity for their primary care and then everything else is part of another system, then yes, you're going to get some misattribution of spending to the entity where the PCP works. Okay. I will also say that there will be a number of health plan members, patients who are attributed to PCPs that are not part of very large provider entities. And so their spending won't be reported at the provider entity level, because the provider, they either will not be affiliated with any large provider entity. They're just a standalone small practice, or the provider entity with which they are affiliated will be too small to meet a minimum threshold for data collection and for reporting. So when you collect, or when OCA collects TME at the provider entity level, it will not be for 100% of the population for any of the markets. Rick?
Follow up. I mean, there is a sort of policy decision about whether to only do this for capitated patients or to try to do some sort of attribution. My understanding, correct me if I'm wrong, is that Massachusetts only does this for capitated patients on the provider entity level, that they're unhappy with that decision, and that the other states that have taken this approach do use some sort of attribution. California, we have obviously more patients in capitated arrangements in HMOs than most other states. And we could potentially, limit this to folks in capitated arrangements. To me, it would make sense, even with the errors that will be inherent in the attribution method, to still, try to get other patients involved in this. But
I think, and given that that spending tends to be more contained in the capitated environment anyway, studying the thing that is not the problem is, I get it. It is imperfect, as you said. Yeah.
Yep, it is.
Just waiting for the slide to load.
Yeah. It's quite traumatic.
Bit of delay.
Oh, there you go. OCA's approach for measuring TME. OCA will develop methods to measure performance against the target for the provider types listed here. These include large health systems, physician organizations, and FQHCs, for which TME can be attributed through primary care relationships. Hospitals, physician organizations that don't have primary care clinicians, The specific approaches OCA will use include primary care attribution for measurement of TME for entities with primary care clinicians. We'll have to develop alternative methods for assessing healthcare spending for provider entities for which primary care attribution is not possible. Next slide, please. So as part of our, next slide.
Yeah, I'm trying.
Okay. So as part of our information gathering to develop this approach, we're going to be examining global risk contracting, capitation payments, and other delegated arrangements for the purposes of identifying provider entities and measuring spending. OCA will also identify other spending, other provider entities for spending measurement and accountability purposes. So, you know, this bullet is distinct from the one listed above, which is more dealing with risk sharing and other type of delegated arrangements. So with that, just want to open it up to any questions that the board has about OCA's intended approach.
Michelle, how big will the provider organizations need to be able to expect them to report?
Yeah, that's a good question. We, you know, other states do have some type of minimum lives for a provider entity, just so that you have that statistical confidence and measurement. I turn to Michael for other kind of more specifics. I think other states do kind of define a numerical cutoff for certain providers, or.
Yes, and it's a judgment call. It's also a capacity call too. We are planning a process to try to assess what the volume of attributed patients are by provider organizations and by market to get some sense of the lay of the land to inform a decision about where to set a threshold. But we're not there yet.
Well, what about the new direct primary care entities like Premise, Crossover? Are they captured in this? They're having direct arrangements with employers for primary care?
If payers know about it, yes. If payers don't know about it, no.
And self-insured employers would not be considered payers in this case?
Well, no, I'm sorry. If TPAs and insurers know about it. So if there's a TPA that's making the payments,
right, then
yes.
But if it's a direct arrangement with a self-insured employer, then no.
Okay, it's invisible to us. We would have no means to know about it.
Okay.
I'm confused about the measuring performance against a target for hospitals and other providers. You know, we heard lots of slides and very helpful information about the provider entity part or the physician organization part. Can you say a little bit about what you're thinking or imagining around kind of hospital targets and measuring performance against the target? And is this data that would be coming from the same kind of payer side, or are you thinking about this coming from the data that HCI already collects in annual financial disclosure reports? Or this is just kind of, there's some bullets on the last two slides, Vishal, that you presented, but no prior information about this. So it's kind of a black box.
Yeah, that's a good question, and it kind of relates to also what Sandra mentioned. I do want to go back to kind of the intent of the legislation, and it does call out the healthcare entities that are subject to the spending target. So those would be payers, providers, and fully integrated delivery systems. So for providers, it includes physician organizations, and we've covered a lot of that today with the primary care attribution. For hospitals and health systems, and also want to mention for physician organizations, there is a definition in the statute, kind of in terms of the numerical size cutoff is 25 or more physicians. And then for Rick, regarding your question about hospitals and health systems, that is something that we are working on, and in the, the intent of the legislation is to hold all these healthcare entities accountable to the spending target. So we're still working through the approaches, and we'll be returning to the board at a later date for more specifics.
Thank you.
This may not fit here, but so now that Optum or United or whoever owns half of the docs in the country, like, how will they be measured?
Yeah, so Optum shows up as a medical group. And in fact, in other states, Optum's being measured and reported.
Okay. No other questions at the moment. Let's keep going.
Okay, according to my notes, we were going to do a public comment here. Is that right? That's still the plan?
So we can. I want to just do a real time check as to where we are. We're committed to have 1 hour more of the meeting. So we'll take some public comment now, probably do another 30 minutes of presenting, and then wrap up and close with general public comment. So let's go ahead and take public comment.
Thank you. So looking to the room right now, it looks like we have 2 folks approaching the podium. We will alternate between the room and virtual. Go ahead.
Hello, folks. My name is Steve McDougall. I represent labor on a JPA that provides healthcare benefits to public employees. That JPA, I'm the president of the JPA representing labor, actually. That's the municipalities, colleges, and schools insurance group based in Monterey County. And geography does matter. You'll be hearing from us every meeting moving forward. And I'm just going to leave it with one anecdotal story. And that is this. We only have one plan that new teachers with growing families can afford in Monterey County, because it intentionally carves out the hospitals in Monterey County that are absolutely hostile towards HMOs or anybody else coming in to create competition. And that's got to be broken. We've been working on it for a decade. Hopefully you can get some help here. We actually coach our new hires to get into the PPO Select plan. And if they're having babies, their birthing plan, per our directions, is to get in a car and get across the county line. And that's what they do. That's got to stop too. Stay tuned. Thank you.
Looking for virtual public comment now, seeing none, staying with the public comment in the room.
Good afternoon. I'm Patrick Pine. I'm the administrator of the Robert F. Kennedy Medical Plan, which is United Farm Workers Taft-Hartley Trust. And you're going to hear more about Monterey County from me. Sorry about that. I'll keep my comments brief. I did submit written comments at your last meeting when I believe they were relayed to you, but I want to expand on that because I had a chance to be in Sacramento today and I live 5-hour drive away. So our plan is always under pressure to keep its costs low, not just for the benefit of our farm worker families that we represent, but the employers who pay 99% of the cost of the plan that we have. So I have multiple bosses. I serve the union, I serve the employers who are paying the freight, and all the union members who benefit from the plan. And over half of the members live in the Monterey County area. We also have members all over the state, so we have some basis for comparison our costs in Monterey County to almost everywhere else in the state. But what we know is that in this discussion that you're having, you're understandably doing like other states, looking at how do we control future cost increases primarily on a statewide basis across multiple sectors. And that's a perfectly understandable approach. But as you just heard from the gentleman before me and from others, some of us are looking at maybe encouraging you to consider a slight alteration in that approach. And that would be to consider what we already know. We know there are certain geographic areas and certain sectors that are much higher costs than the rest of the state. So I'm here to encourage you to consider going forward, perhaps modifying the
10
approach
seconds.
somewhat to attend to those extreme differences that we're already familiar with. And I do not want to underestimate the challenge for you in doing that. We're very supportive of what you're doing, and it's an incredibly complex challenge. So we appreciate what you're considering, and I appreciate what I'm asking you to consider. But here's the reason why. We know that the 3 hospitals in Monterey County, which are Community Hospital of the Monterey Peninsula, Salinas Valley Health, which used to be until recently called Salinas Valley Memorial, and Natividad, which is a county hospital, all 3 of them rank highest costs for hospital care, not just in the state, but in the entire country. We have data to illustrate that their costs exceed Boston and New York markets. We have data to illustrate other things. We've looked at their cost reports. We've looked at other indicators. By any measure you want to look at it, those costs are just out of line in all respects. And it's not just our plan. I can tell you all the other labor plans with multiple populations in that
You
area.
got 3 minutes.
Their public sector plans have the same issue. So I'm just here to encourage you to take that into consideration. We appreciate that. And I want to tell you that I do not underestimate the challenges you have with the data. I've been dealing with this for a long time, and there's just so much data that it's almost becomes overwhelming sometimes. And I think that's the challenge. How do you decide, well, how much data is enough?
3 minutes and 30 seconds.
Is it too much? So I appreciate your time. Thank you very much.
Thank you.
Virtual. Seeing no virtual public comment, we'll go back to the room.
Good afternoon. My name is Katie Bassler. I'm the president of the Salinas Valley Federation of Teachers. I represent the certificated staff in Salinas that unfortunately falls in Monterey County. I won't repeat what the gentleman before me said, but my statement to all of you echoes it. We cannot attract educators to Salinas and have them stay because they can't afford to build families in Monterey. They have to either pay the high premiums to get coverage and deliver. God forbid they have to have a cesarean in Monterey County. We urge them to go and deliver outside. It is a moral imperative for our communities to have quality educators. But when employers can't even attract them because educators can't afford to live in the area, and healthcare is probably, after housing, the second highest variable. This work ahead of you is necessary. We've tried on a small scale to poke at the Salinas Valley Memorial Hospital. We made some headway through shaming them, but it has to be done on a comprehensive level, and we appreciate all of your work. Thank you.
In the room.
Good afternoon once again. Cesar Lara with the Monterey Bay Central Labor Council, and to echo some of my colleagues, just a little bit of geographical area. 2/3 of all jobs in Monterey County are in hospitality and ag. So a lot of housekeepers, a lot of farm workers. Average salary is about $28,000 a year. And we are in a state of emergency in regards to healthcare cost. 3 of the top 10 hospital cost regions are those 3 hospitals that my colleague mentioned. So I want to invite the committee to actually come to Monterey County and see firsthand the real frontline county that's really being impacted by the cost of healthcare. Throw in the cost of housing, throw in the per capita highest percentage of any other county around immigration. So something needs to be done. We are beyond emergency status, and if you look at freezing the cost and then increasing slowly. We are already starting at an incredible amount higher than the state average. So we asked this committee to really look into it because working families are heavily being impacted. Their economic future is in your hands. Thank you.
Seeing no virtual public comment, back in the room.
Hi, my name is Lelia. Good afternoon, everybody. I'm from Monterey. I'm here just to ask you guys if you guys could, consider insurance for middle class people, because sometimes the bills are very high. Last December, my husband got sick, ended up in the hospital for 5 days. The bill was almost $130,000, and we're trying to put our kids to college. So it was very difficult for us to make a decision, either pay the bill or put our kids through college. So we decided to pay the bill and still put our kids to college, but it's very difficult to, educate our kids and improve our county. The more education we have, the better future we have in the counties. So I'm asking you guys, if you guys please consider, think about helping us have affordable care for our county. Thank you.
In the room.
Hi, good afternoon. I'm Luis Olin. I'm driving from Monterey County too, and I'm here because a couple of years ago I got a sick condition, and I went to the hospital too, and I had almost a stroke, and I got lucky because and my workplace, then they bring me to the hospital and ambulance and to the shop, and I was in the beginning. After that, I was thinking the bill is gonna be really high, and I got lucky because the employee paid for that. Otherwise, I can afford the payments, and now I'm here asking you for how do you say we need to the hospital is really high right now, and then my coworkers too someone have a condition too, and sometimes it's really hard to pay the bill because the hospital in Monterey is really high, and then we asking for you guys regulate or something like that for the hospitals, the cost lows. Thank you very much.
Beth Capel on behalf of the Teamsters and Unite Here. The workers have said better than I can why it is that the work you're doing is so important in terms of affordability. On behalf of Health Access, we too support the use of the covered California regions. I would point out that Region 1, which is the North Coast, is more than twice as expensive as the two LA regions, and the Central Coast, who you've just heard from very eloquently, is almost twice as expensive as the LA regions, with no apparent difference in quality of care. The covered California regions are not just the covered California regions. For the last dozen years, they have been the foundation of rate review. The health plans who are state regulated in the individual and small group and large group market report their rates and have rate review on the basis of the covered California regions. This will help you feedback into the conversation about how to actually get it to affect rates over the work you do to get it to actually affect premiums and out-of-pocket costs. With respect to the service categories, those will also look very familiar from rate review. A few additional points. It's our understanding that payers are able to separate payer paid from consumer paid. I know that not every state does this, but our understanding is the data exists and it's possible, and we'd ask that the staff explore that and we can provide more technical assistance. With respect to capitated arrangements, Kaiser has been subject to rate review since 2010. They are required now by law, a law sponsored by Unite here to report by budget category, which is identical to service category if they're unable to report projected trend. So that information is available even when they're capitated arrangements. Similarly with risk-bearing organizations, that information is available. I would also note that there are many physician organizations in California, and Vituity, which is on the advisory committee you just approved, is a good example, that have no primary care. It was earlier called California Emergency Physicians. And so there would mean they provide no primary care. They're ER docs and other hospital-based docs. As you get into this conversation, that will be an important part of the tracking you're doing in terms of hospital costs, because some of the costs you heard about in hospitals where the care of the doctor is provided as well as the hospital. Thank you.
No public comment in the room or virtually. That concludes public comment.
Great. Michael, just for reference, we'll try to wrap up presentation around 3:15 so we can leave the last 15 minutes for general public comment. Thank you.
Okay, thanks. Okay, so we're going to start but not finish a conversation about spending target program adjustments. As I said, there are a wide array of adjustments we're going to talk about. States incorporate different types of adjustments into their spending target programs, and as I indicated earlier, your statute identifies some others that are not in use in other states. So what do? They sometimes adjust the value of their spending target once they've established their methodology. So I have an example here. Connecticut established a spending target of 2.9% over a 5-year time period, but they then elected to adjust it so that it was 0.5% higher the first year, 0.3% higher the second year, and then they went to 2.9%. Okay, and I won't go into why they did it, but there are a number of states that have established a tiered introduction of their spending target values. Okay, so this is one example of an adjustment to a value. A second adjustment that they've identified is to consider what conditions might warrant reconsidering their spending target value after it's been established. So, for example, Rhode Island stated that only highly significant changes in the economy would trigger revisiting of the target methodology. And that left open what were highly significant changes, of course. There's another state that said we will only revisit it if there's a substantive increase in inflation, which of course just happened. So there are sometimes conditions that are established by states so that when they establish their targets, and targets are typically established for 5 years, Oregon went as long as 10, but typically 5 years, that they will establish conditions that would allow for a reconsideration of the values for either general or highly specific reasons. Okay, some other types of adjustments. There are a number of states that have developed adjustments to strengthen the accuracy and reliability of their performance assessment. So this is less about adjusting the target than it is about the methodology for evaluating performance. So, for example, Oregon developed confidence intervals and risk adjustment to improve their statistical confidence in assessing spending growth. There are other states, including Washington, that truncate high-cost outlier spending. These are all steps to increase the precision of the measurement because the states are either through public reporting or through more explicit mechanisms applying accountability for performance. And so before they want to apply accountability, they want to make really sure that they are certain about the level of performance of a health plan or provider entity. So again, these are adjustments not to the target, but they are refinements to the assessment of performance relative to the target. And then last, there are provisions in your statute to adjust the spending target itself. So with the exception of the examples that I gave earlier, no other state says the spending target will be adjusted. But your statute specifically identifies where it's either required or permitted. Okay, so that's something different that we will need to consider. So in general, the statute has two different types of adjustments that it ponders. One is modification of the target, and the other is modification of the entity's total medical expense. Okay, so big difference here. Changing the target and adjusting spending performance. And the statute has both requirements and permissions to do both. Everyone following me? Okay, and there are different adjustments that are either permitted or required to the target and to performance. They fall on both sides. So as we begin to walk through adjustments today, I'll try to highlight, is this a required adjustment? Is it a permitted adjustment? And is it to the target, or is it to calculation of performance relative to the target? Y'all still with me? I realize we're getting late into the afternoon. Yeah?
Yes.
Okay. Okay. So for baseline reporting, the only thing that's required is adjustment for population health status, which I'm going to call risk adjustment. And this is adjustment not to the target, but to performance. So we're going to modify performance assessment based on change in population health status or risk. But for performance starting in 2024 to 2025, you can see there are 5 different types of adjustments that are made either to the target or to performance. Right? All of these have not been thought through, and we're not ready to provide you with recommendations on how they be done, and that's okay because we've got some time before they're going to be applied. But I'm going to touch upon all of the topics starting today and as necessary continuing in the next meeting. All right, so I'm going to start with the one that's applicable to baseline reporting, which is risk adjustment. So what the statute says is that the office, in consultation with you, will establish risk adjustment methodologies for reporting of data. It also says, interestingly, that any methodologies selected or used to inform adjustment shall take into account the impact of perverse incentives that might inflate the measurement of population risk, such as upcoding. And then it speaks to the ability for the office to perform an audit. So let me talk a little bit about risk adjustment. So risk adjustment or health status adjustment is a process whereby a payment, quality performance, or some other measure of performance is modified by a risk score, typically by calculating through a multiplication a risk score relative to the performance measure. Okay, a risk score for purposes of measuring spending estimates how much it will cost to care for a patient relative to the full population of patients. So typically the measure is going to be the population is going to be a value of 1.0. So if the expected spending is going to be above average, it might be 1.1. If it's less, it might be 0.9. And the risk scores are typically calculated by looking at the demographics of the patient and also typically based on diagnoses as appear on claims driven by utilization, okay, or their claim history. And there are all sorts of software algorithms that do this. Rick, a long time ago, developed one of them that is still in use. But there are many of them, some public source and some of them privately licensed. These risk scores are commonly used in payer-provider contracts to adjust dollars that are allocated to provider organizations. The idea is to match resource needs and payments so that payments are higher for people who need more services and they're lower for people who don't need more services. That's the intention behind all this. This next graphic, which we'll slowly unveil, there it is. This is borrowed from the Massachusetts Health Policy Commission, and it shows a couple different ways of doing risk scores. One is just to look at the age and gender of a patient, usually in combination. The other factors in the health conditions of the population. So you can see in the bottom example that there's consideration of the fact that a patient has diabetes, whereas if you're looking at age and sex, that's not considered. All you're going to know is that people of a certain age and sex cohort on average have spending that's higher or lower relative to the full population. But if you factor in medical conditions, that's going to provide additional information. So a higher risk score in theory reflects a sicker patient population, but it also reflects utilization and access to services. Because if you don't have access to services, then you're not going to have the claim that's going to have the diagnosis that's going to influence your risk score. So here's a case example of two fictitious patients. Alice lives in Oakland. She's got a barrier to accessing care in that she's got limited child care and can't access work around her work schedule. So in this particular fictitious case example, she's been having some symptoms, but she waits to go access care because she's got economic barriers or what we might call social risk that limits her from getting to care. The other example that you don't see temporarily is Gabrielle. She has a job where she can take a day off of work to go access care. And so her symptoms she's able to have addressed in a timely fashion. So in this example, Alice, who lives in Oakland, if she doesn't go for services during the year, because between childcare and having a job that won't let her take time off, she's not permitted or not able or impeded from doing so, then her diagnosis isn't going to show up on a claim that year. And so her risk score will appear to be lower than if she was Gabrielle, who was able to go access care more easily, has services, and her symptoms lead to a diagnosis that shows up on a claim. There's growing research on rising risk scores. This is just one example. This is from a paper in Health Affairs that looked at risk scores in the Medicare program using the Medicare's HCC grouper. And they compared rising risk scores to patient self-reported health status using the CAP survey. and found that the HCC risk scores rose much faster than the patient self-reported, suggesting that coding was having some impact. I will say there are growing numbers of analyses that look at this. Massachusetts Health Policy Commission has done extensive analysis looking at the impact of coding on risk scores. And it's frustrating because we know that there are changes in population health status that occur over time, but it becomes very difficult to pull apart what are changes in coding practices and what are changes in population health status. So let me tell you now what states are doing with respect to risk adjustment in their spending target programs. So states typically do not apply any risk adjustment at the state level or at the market level because the populations are so large at that level, and the changes that typically happen in health status over the course of 1 year are going to be small enough that the states haven't considered risk adjustment to be necessary or appropriate. But states have contemplated risk adjustment in assessing performance against the spending target at the payer and provider entity level. And again, it's payer by market because those populations are smaller. And there are changes that can occur over the course of a year. Imagine you have a very large employer group, I'll pick CalPERS, that decides to move from one payer to another payer in the course of a year. Population's large enough that that shift in population could easily impact the risk score for a health plan. So states have looked at applying risk adjustment here so that there's fairness in assessing performance against the spending target. And so that neither a payer nor a provider is held accountable for a change in spending that's really due to the fact that the composition of their patient population or member population changed in the course of a year. Okay, so some form of risk adjustment is standard in other states at the insurer and provider entity level. All right, I've been talking without taking a breath for a while, so let me pause. Any questions or comments, and especially, Rick, since this is your area of expertise, please add anything you'd like to add.
That's a good endorsement, and I see Richard Pan's hand up, so we'll go to him first.
Thank you for the presentation. I think that, a couple thoughts. First of all, if I recall correctly, someone looked on the statute, there were several things that we mentioned in terms of, we have population demographic changes, right? The population's aging. Usually when you're older, you have more healthcare needs. We have other factors as well, technology changes. We just came out of COVID, so let me just pick COVID, for example, and I certainly understand when you talk about like state or market, do we need to do risk adjustments? Well, so for example, there's research showing that people have gotten COVID, particularly children. Actually, a paper just came out, have an increased risk of diabetes. Actually, now they're estimating twice the risk of diabetes. So that's a population change, like when HIV came out, et cetera. So we do have these things that affect entire population. We can argue in terms of how much of the population, but those are, you could have major changes. COVID certainly is a pretty recent example of major impacts on health status across the entire population. So we got to take account of that because that's going to drive up need and utilization. I certainly agree that there's a challenge with people upcoding because as soon as they know the coding is tied to payment or TOS targets or something financial, sometimes people try to game the system. At the same time, it's important to realize that it's not all gaming. Some of it is actually real stuff going on underneath, right? And so I do think, part of the reason we also explicitly have an equity adjuster is for the same reason for the example you gave there, right? So we realize that someone with diabetes who's middle class is not going to have the same, may have different set of costs than someone who's diabetic in a low access, area, right? And we actually want to create incentives for people to go and actually serve those populations. Also, there may be more social terms of health issues related to their disease, right? Really, that then impacts the healthcare costs. So, I think that those are explicit reasons for doing the risk adjustment, the equity adjuster, which I know you probably talk about a little later. We need still the equity adjuster technology still needs to be developed to a certain extent. But I do think that it's, I'm a little concerned we're either trying to minimize or write off risk adjustment when our direct experiences, even just the last few years, is that populations don't stay the same. There's sort of slower stuff, demographic stuff you can predict, and then there's stuff like COVID that shows up, right? Or other types of things, new technologies that show up, new treatments, and people want access to those treatments, and so those have to be factored into any sort of cost targeting that we're doing.
It's just two points. This is such a hugely complex topic, and I hope there's some more discussion about it. On the question of sex and age-based adjustment, I mean, I'm sensitive to the attraction of that, but at the same time, occupation is a huge factor, and as a proxy for other issues, including equity. I don't think any reason we can't do both. We have to select one as the basis for going forward, but we could do clinical risk adjustment and monitor it. So we have the option of changing the methodology down the road. Also assessing whether certain...
Hey, Richard, I believe that the internet in HCI just went down for a few minutes. We're trying to get it back on.
Thank you.
You're welcome.
Hold your question, David.
Okay, seems to be back.
Is it back?
I can see everyone.
Yes. Just before we move on, let's make sure we are. Okay. David Carlisle, then Rick. Go ahead, David.
Yeah, so here was my next slide. So this is what other states have done. So Massachusetts studied risk scores. They found they grew significantly over a few years, and they could not find any supporting evidence in terms of disease prevalence or demographic changes. So they are now recommending reporting unadjusted spending, which is what Nevada wound up doing. Rhode Island found that risk scores in 1 year, 2018, 2019, grew 4.5%, and the effective impact on their target was to grow the value from 3.2 to 6.4%. So if you include clinical risk adjustment and the scores are growing that much, you are effectively raising your spending target to very high levels. And so Rhode Island decided to move to age sex adjustment. Since that time, New Jersey, Oregon, and Washington have all moved to age sex adjustment. To answer your question, David, I don't know. I was there. I don't know why Nevada decided not to go with age sex and just said, forget it, we don't want to do any adjustment. But they did. And as you can see, the Massachusetts Health Policy Commission's recommended the same. I will say that age sex adjustment does have an impact, but it's modest. It's modest from year to year because I've seen it applied, but it does have an impact.
Rick, and then Sandra, and then Don.
I strongly support, and we haven't gotten to the recommendation, but we have only 2 minutes left before we're supposed to break. So I'm going to jump and assume that people have looked at the recommendation. I strongly support the recommendation of using age sex adjustment and not using diagnostic adjustment. And Richard, Pan, I look forward to a more than 2 minute discussion with you on that. I've been working on this for 15 years. It's sort of my Don Quixote tilting windmill stuff. But I think it would be a big mistake to use diagnostic risk adjustment, as Massachusetts has come to realize. The one question or thought, though, is I think that adjusting for clearly measured characteristics that we know are strongly related to spending beyond age and sex does make sense. And I'm thinking here about Medicaid beneficiaries with disability or Medicare beneficiaries with disability. You know, a 35-year-old Medicare disabled person is going to have much higher spending than a 35-year-old who's not a Medicare beneficiary. And similarly, you know, a 40-year-old Medicaid persons with disability will have much higher spending than someone who's of the same age and gender without disability. And you know, if provider entities are thinking about how they're structuring their services, we don't want to disadvantage the entities that might over time be serving more people with disability. And disability is, you know, not it can't be manipulated by the providers very much, you know, maybe a little bit.
And you're referring to Medicaid disability status?
Yeah, or Medicare disability.
Or Medicare, yeah.
For you know, under 65 people. And there may be some other characteristics like that, nothing that has come quickly to mind, that are strongly related to spending, but not within the control of the provider.
Okay, David, and then, okay, and then I think Don. Okay, go ahead, David, then Don, then Sandra.
I just make the point, I'm not fluent in this area, but I know that there was a controversy involving a risk adjustment bias that had disparate racial ethnic outcomes in the algorithm. I won't mention the name of the organization that was I associated with this, but this is something that has been recognized.
You are. Sandra? Others? Richard Pan, I can't see you at the. You're good? Okay.
Oh, now he has his name.
Now he has, okay, jump in.
Yeah, sorry, and unfortunately, I didn't hear what Ian had to say. That's when we got cut off. I certainly understand the concern that's being raised about diagnostic. I think that the idea is, I appreciate what I think Richard said that, or I'm trying to remember who said because I can't see. You know, there's a difference between, okay, we're going to do every diagnosis has an adjustment, right? To you have people with fairly significant chronic diseases or disabilities that are hard to say that they, you know, that there's a clear line between them, and there's actually significant cost differences, right? So people who have cancer, certain types of cancer, or major disabilities, or other types of things. And I think and what I don't want to do, and I think is mentioned, is that essentially we don't want entities going, oh, well, you know, we know they cost more, but we're not going to get an adjustment on our, you know, cost target. So this is not so much the statewide cost target, but it's for entities. And so we're not interested. We either want to avoid them, right? And we see this with adverse selection by risk-bearing entities because, you know, on an ongoing basis. And so we don't want to create disincentives for taking care of people with either complex medical, chronic medical conditions, because they're not going to get solved in a year, right? So they're going to be an ongoing, quote, burden on the payer who has that person, and so I think that's one of the things that I don't want us to create essentially a disincentive for. And we already know that this incentive plays out in terms of when someone says, oh, I need to bring my costs down, how do we essentially drive them? And actually, that's what unfortunately makes mental health. No one wants to be the best mental health provider now, never, right? I mean, who wants? I hate to say this, but I don't see people going around boasting about how great their mental health coverage is and what a great network of mental health providers they have, because people don't want those patients. Those patients cost money. They have ongoing problems. Most of them you can't treat and have everything go away in a year, right? Same with substance use disorders. So let's not create those kind of disincentives. I think there's a middle ground to be struck, right? And it's, again, I get it, we're prone to manipulation, but also let's not create disincentives to take care of people, especially with chronic diseases, major complex medical or disabilities.
Okay, given the time, Rick, I don't know if you want to have any feedback to Dr. Pan. I do think we will have a chance. This is too big an issue just to say, hey, we're done. So we're going to come back to it. And I would actually recommend that to our team that the next time we pick it up, we almost lay some of the quote pros and cons so that the board can see it and spend some time with it before the next meeting, come back. David, appreciate your reference to some of the history of this and whether it creates some bias or slant that we want to be mindful of. And I know others have some feedback. So unless you had something burning to say now, I would say let's wrap this piece up. I think, Vishal, if you wanted to, if there was one last slide you wanted to present, but I'm eager to get the public comment and know that we didn't get through everything that we intended to, and that is okay. We will get there next time.
I could quickly go through this slide. So OCA's tentative approach is to use age, sex adjustment only. The thinking is that this will capture the impact of an incrementally aging population, which may be the most significant change affecting population health status over the course of a year. And you know, as much of this discussion was covering, it would avoid the distortion associated with coding practices. This would involve establishing age-sex bands that will be adjusted based on relative weighting of those bands and uniformly applying them across insurers and by market. And we would also standardize the risk adjustment methodology across insurers.
Okay, knowing that that's the proposed approach, I think to get the full feedback, we'll probably be able to come back to this in the next meeting. And I appreciate the robust and important conversation we had. Michael, thank you. Vishal, thank you for helping us get through this. Let's move to public comment.
All right, seeing none virtually, reminding folks virtually to either raise your hand or if you're dialing in, press *5, but looking to public comment in the room.
Beth Capel on behalf of Health Access California, to acknowledge that there are many members of this board who know far more about risk adjustment than I do or ever will. To note that the statute does distinguish between how the statewide targets are set and how the entity level targets are set. And in the heat of the moment, it is hard to distinguish those targets which are subject to unadjusted reporting as well as risk adjusted reporting, but that is also encompassed in the statute and was an important foreshadowing when we had within the legislative process a discussion about including risk adjustment. Clearly the discussion about upcoding is pretty important and a salutary lesson for California. It's every once in a while, it's nice not to be first out of the gate and to learn from others. We do share and understand Dr. Pan's concern about the avoidance of not only high-cost populations, but high-cost treatments. It is one of the classic responses to cost pressure, whether it's the AIDS epidemic or avoiding coverage of Sovaldi or dealing with long COVID. And so I will trust that we will think about this and try and find a way through it, and that the board will revisit this question from time to time as information develops, and certainly look forward to a fuller discussion at the next board meeting. Thank you.
Full public comment will stay in the room.
Once again, I'm Steve McDougall. I'm taking off my mixed sig JPA hat off as president. And coming out of the cesspool that is navigating healthcare in Monterey County, that is ground zero for the worst problem in the country, by the way. Highest medical inflation rate in the country is right in Monterey County. It's been that way for probably 10 to 15 years. But back 30,000 foot view of California. I happen to be a teacher in Salinas, in the Salinas Union High School District, but starting late last week. I also have a new title, and I am the president of the Council of CFT's local of early childhood through high school education teachers. And there's over 50,000 of us that I represent, have their voice under the president, Jeff Freitas of CFT. And one of the things that we talk about when we have large conversations around bargaining, you probably have seen it in the news in recent times, there's a teacher penalty. And that is teachers are making about 26% less, depending, más o menos, of their similarly educated peers in California. And then you couple that with the cost of healthcare. And when bargaining happens with employers in the education sector, choices have to be made. Are we going to try to keep up with already being behind a quarter of your peers and try to come up in salaries? Or do we have to apply it to the cost of healthcare? And oftentimes it's to healthcare, a lot, if not only, depending on what's going on in economic factors. This is not going to maintain the cornerstone of our democracy, and that is a free and appropriate public education. We got to be able to attract and retain teachers, and having healthcare that is affordable in California is a very important piece. So thank you for your work. Stay tuned.
Virtual public comment and no one else in the room. That concludes public comment.
Okay, well, I didn't think we were going to get to be on time, but we somehow did it. I acknowledge that we didn't get through everything we wanted to, and there's more to say here. Any closing comments by my fellow board members before I adjourn us? Seeing, Ian, please go ahead.
Since we have 4 minutes, I just want to really appreciate and acknowledge the long distance that some of the public commenters traveled, and it raises for me a question that I realize is a huge challenge organizationally, but maybe staff will consider over the long run, maybe from time to time holding these meetings elsewhere than Sacramento, because I think that public comment is so helpful to our deliberations, and facilitating it for people who are unable to take the full day off to come up here or get on a plane is worth considering.
Yeah, I think it's an important consideration, and I'm really glad that we still have a virtual option so that public comment can be made. Not to say that it replaces it by any stretch, but I hope that that balance is, continues to benefit us. But good flag. All right, again, Richard, if there's anything you want to.
Actually, just a quick question regarding our next meeting in June. I understand there was some consideration to actually start earlier for a longer meeting. I just want to know what the status of that is, since we're all here together. I'm the only virtual person. Has that been decided yet? So we can plan for my June. Well, we can all plan for our June calendars. So, meeting date.
Oh, for a longer meeting in June? Was that the request?
Yes, there was a proposal.
Yes, we did talk about it. I clearing up my schedule for June is a little tricky, so stay tuned. But if we can accommodate, and I think it's important, as the case is today, a little more time committed on everyone's schedule would have been helpful. So we will continue to look at that, and if we can make it happen for June, we will.
Well, Chair, I appreciate, and I know how busy you are, and tremendous respect for everything you have to get done. And I know that July is the new fiscal year. I guess the rest of us also have calendars. I want to know whether I need to be here earlier or later because people are already asking me about my calendar. So do we know when that decision will be made?
We will try to make it by this time next week. How's that?
Okay. All right.
Okay.
Thank you.
Sandra.
So just one thought that came up in listening to the presentation on where we get data from and what kind of data we can pull around encounters. It might be helpful at some future meeting to get a little update on the all payers claims database, just to understand where that is as a tool moving forward. I don't know when that works into your schedule, but I think that'd be helpful.
We're very happy to do that, to plan for that. So we're incredibly excited. Our all payer claims database called the HPD, the Healthcare Payments Data Program in California, is required by law to be substantially complete by July 1st. And we're going to have a lot of information coming out in June. So we'll figure out whether it makes sense to do it in a June or July. Noted that there were a lot of use cases raised about the HPD in today's meeting. So it's a great point, Sandra, and we will do a presentation about the HPD at some point.
Okay, Ian, we used all 4 minutes. Well done, well done. Okay, thank you. Thanks everyone for attending, for coming up, for being here in person, and to the board for the commitment of time, and to the staff, appreciate the presentations. See you next month.